try and respect the timetable so that all presentation have the time that they need to explain what they want to present. Then we will have do the exchange. As you know, this panel is the challenges of relating to gaps and interpolations of the law of territory and mental health in our country. Before beginning, a practical point for those of you who will do the practical in the territories. The lists are outside, so you can see where you have been assigned. If anyone wants to do the practicum who is not on the list, they need to speak to the help desk, which is down on the first floor, information desk, so you can resolve this issue. When you go out, please see that the lists are on the door of the room. What I'm going to do now is invite our speakers who are going to participate in the panel. Initially, it will be Camila Solis. I will then introduce them with their merits and see Alejandra Moreira, Professor Julio Braida. He's on his way. Dr. Daniel Márquez, licenciada nurse Risi, our psychologist Di Pasqua, and Ma Monza, graduate in philosophy. This is our panel who we have today with us, and they will be sharing different experiences. Firstly, we're going to begin by explaining briefly which are going to be the main issues which we're going to be discussing today, the challenges which we are proposing for this occasion. If you could come to the first slide, please. It is the challenges between the new law and the territory, gaps and needs. So, the interesting thing we're going to do is try and go into a little bit more detail about these accesses that we think should be interesting for the discussion. We want to consider good practices in primary health care, and that is the first things we're going to talk about today. They bring key elements for the development of a communitary model for mental health and for overcoming stigmatization and access barriers in mental health. Also, we must consider that providers have often had difficulties in effective implementation of new proposals of the new mental health law. And this has also complicated things to be able to, for this new law that suggests a communitary focus in networks, and we need to reorient mental health, and it needs to go deeper in. We need to understand this greater community aspect. Also, we need to consider the tendency we have of medicalizing the approach, and that makes it even more complicated for medical specialists, especially for psychiatrists, and that generates a considerable gap between mental health demand and capacity of the services. And then finally, the process of our professionals in all levels, both at undergrad and specialist training, and the moment of choosing their residency, and at all levels of their training. Our professionals in the territory, they have limited opportunity to train in the territory itself, and is also considering the levels of community and Montevideo, and that also limits the possibilities of training. We think it's also important as a general point is how can we move forward with this approach, a community approach in the private sector and also the public sector. And that is what the National Integrated System of Healthcare brings to us. That is what we want to share of our experiences. And firstly, we're going to ask Camila Solis, who's a psychologist, she has a global King's College London magister in mental health, and she is a consultant in mental health for PAHO and for the WHO. We're going to ask Camila to give us a share and a perspective, technical perspective of these challenges. Thank you. I want to thank you for the invitation. This is also a special instance because this is my first assignment working as a consultant for mental health in this country. So this is a fantastic opportunity to have a greater perspective. And that's where I want to begin. The great question that we have, the great question that we need to ask is how to move forward in a community-based model and approach. The first thing that we should say is there isn't a single path. And sometimes that doesn't sound very encouraging, but it is all good news, really. Because when one designs and plans a transformational process, you do a process which is based on the community, and it has an important integration of mental health in primary health care. This needs to be adapted to the characteristics of the system, the healthcare system, of each country and the epidemiological profiles of the country, and it needs to be adapt to current challenges regarding mental health. In the previous panel, mental health continues to be challenging for every country, especially after the pandemic. So it's not the same to think about integrating mental health in primary care in what it was 20 years ago and what it is now. And we see that there are very important challenges such as vulneration of rights, restoring dignity. And those are challenges which are present, and we also need to consider the global threats that we saw during the pandemic. There was a nearly 25% increase in mental health problems around the world, and that also created bigger gaps and highlighted gaps in care, which was considerable in many countries, especially those with a lower development index. We need to develop a model which responds to this, and it needs to be an integration in primary healthcare which is more flexible, adaptable, and resilient. That's the first idea. And then another thing we can recognize are these elements which are essential for integration of mental health in primary healthcare. Also a key element to move forward of deinstitutionalization. This implies not only a change or we need to think about transformation and reorganization of services, and that implies a change of focus. We need to change the focus from a biomedical focused on disease and sees mental health as an individual problem towards a psychosocial model that is a social model of healthcare, and it considers the impact of social determinants in mental health. These days we have robust evidence that says that people in adverse social situation have more risk of developing mental health issues, and that implies, and we saw that in this morning session, it is even greater changes that are related to a change in mentality and a change of focus. And that is one of the challenges that is going to be discussed on this panel. It's a critical element in the human resource training. It's also important to consider what resources we have and what can we change, so that way we can generate a change with a redesign and a greater change in the model. This it doesn't only imply training specialists in mental health, and from PAHO it will be psychiatrists and psychologists, people who have training in mental health. This is not only a challenge of changing the focus, but we also need to think about training in mental health of other professionals who are involved in primary health care. The challenge doesn't end there, because as we also saw this morning, training territory agents in the community that will enable us to give a response to people timely for accessible. So we have challenges which are considerable regarding training. And here I want to round back to in what do we train them in, and how to do mental health, make it more accessible, but also training our human resources who are able to do management with a social model based on the community, who can develop these changes and implement these changes. And this is the role of university and training centers, which is of course important. And we'll try to go quickly, and time is going past.
Of course, an important principle is the transformation of services and the inclusion of mental health in PHC, which should be a key part to move forward. What happens is that mental health is very important, but we know it lies behind. And when we thought about the processes to strengthen this care, or whenever we're thinking about reforming primary health care, mental health isn't at the key or at the center, moving together with other non-communicable diseases. So in fact, we need that this is in the agenda.
Principio central.
Another key issue is human rights. We know that people with mental health have historically been more exposed to the vulnerability of the rights. So it's not only because we want to change to a community-based model that we're going to reproduce exercises where we restrict the autonomy of people, decision-making that people have, or how to set up your own personal project in the community. So that, in fact, is a principle that isn't present only in the model, and that by simply thinking about a community-based model is solved, but we must have it present at all times. Practices that are evidence-based. When we started psychiatric reforms, included a strong ethical component that's still in force. But we also know that community-based models in mental health produce better results. And we have to move forward in that area. The fourth has to do with the social determinants on mental health. We know that the sooner we get closer to people keeping their mental health will reduce the risk of being ill. So we have an enormous challenge to get there earlier and to accompany people not only when they fall ill, but to keep their health up. The multisectoral approach of social determinants requires, in fact, the introduction of specific questions and effective issues to protect mental health, to approach social determinants. The intervention in mental health is not only health, it's provided by health. We have to put a focus on that. We have experiences in our continent, for instance in Brazil, of how poverty mitigation measures have an important impact on mental health, together with other interventions, apart from the psychosocial issues. So we have to integrate actions, and we have to generate a more strategic, multisectoral approach with better results. I'm Chilean, and in Chilean we have this syndrome of tableism. We have lots of tables to think about this and to get better results. And then empowerment, the people who are cared for, and that's a focus that we have to put on. We have to think that people who are users of the system must be present right from the design, implementation, and evaluation instances. And there's also a challenge that was raised in the previous session, the participation of community agents to provide responses and strengthen mental health in PHC. Now, essential requirements then. In fact, we are repeating essential requirements to transform services of complex systems. Governance is important. In relation to governance instruments, we need a political commitment. And this is because the change in the introduction of mental health in PHC is a systemic change. This is one of the main mechanisms to move forward in this decentralization, to move in the cellular model. And we have to look at the entire model, not only introducing more psychologists or mental health teams in PHC, but we need to look at the system differently. And whenever someone goes to a general health care, that person must detect that that person needs mental health help. That's why the provision of services must be rethought. And we have a large challenge to try and share responsibilities and delegate functions to non-specialized staff in mental health. That's one possibility of expanding coverage in PHC. And also about the challenge that we're mentioning. The answer is not only in training more specialists. We have to take into account that only 4% with mental health problems will require a specialist. In fact, we have to strengthen an earlier response. We also have to make effective and the access to medicine that allow for strengthening comprehensive care. Pharmacology is not the key intervention. It's a pillar, but it must be present in PHC because it can look into more complex issues, but that should be their primary level. And we also have to reinforce information systems that allow us to assess responses. I would like to conclude leaving you with two ideas. The idea that mental health can't be left behind in the processes to strengthen primary assistance and change processes. The pandemic scenario is still an opportunity process. Good practices are our opportunity. And perhaps I'd like to share my last point with you, and this involves participation. We require consensus for change, not only of those who have already been persuaded, but those who have not. And the participation of users and family and carers as a cross-cutting pillar. Thank you very much.
Muchas gracias, Camila. Ahora le vamos.
Thank you, Camila. We're going to give the floor to Alejandra Moreira, who coordinates the mental health area in the Ministry of Public Health, so that we can have a vision from the ministry. Thank you.
Bueno. Bien. Bueno, muchas gracias.
Thank you very much for asking me for this very prestigious table, and it's an honor and a pleasure to share this time with you. The first thing I wanted to deal with is how we are, what we are doing, what our main problems are. Our problems in Uruguay refer mainly to have access to health care in mental health, and it's not only our problem. This is shared all over Latin America and the Caribbean, as well as in European and Asian countries. This is a world scale level. There is a study, there is a report that I find very interesting that I shared with you yesterday. It is called Mental Health in the World. It's not assessing it in terms of mental disease, but it assesses mental well-being, and it builds a very good indicator measuring the mental health, the mental status in terms of welfare. It is trying to obtain it, prospering and keeping on. I think this is very innovative, and we have to start thinking about mental health in terms of health, not in terms of disease. Edmundo Granda, very well-known author of PAHO, since the beginning of 2020, he says medicine was looking into microscopic diseases, that idyllic idea that if we can extract diseases, we'll get health. But things are far more complex. Mental health is influenced by very many indicators that involve social issues as well as family, relatives, housing, and that's why it's so difficult to make changes. We're talking about this. We've been talking about this for many, many years. 1970, we had the Caracas Declaration, then other declarations. In 1990, this was transferred to the change in the model of health care in mental health. And so we're trying to find health care in the community more accessible to people and accessible at the simplest level. People who have no money to buy the bus ticket to get to a clinic that is 2 kilometers away. It's a short distance for us, but there is an important barrier to have access to care, and not to think about people who have difficulties in their mental health. They will have problems, and they will feel ashamed if they have to say that they're going to be treated mentally. So in Latin America, we can see that there are countries that have a very good mental health level. However, suicide levels are very high. We have Guyana, Suriname, and Uruguay with the highest suicide rates. So it seems that suicide isn't directly related to well-being. It is related to many other things in the intersectorality that are involved therein. And the study shows that people in the world have stigmas from the pandemic, and mental health became worse. And in 2022, we are looking at 2021, 2022, and 2023. We haven't been able to recover. Changes haven't been that clear. And what is really most worrisome is that those suffering the most have been young people, teenagers who have been desocialized from the life of any teenager. They must socialize. They must be with friends. They must have other vital processes. So we may think, what is having an impact on that? Why is it that populations are sad? Why is it that we have these mental health rates? Why have consultations increased exponentially to over 100%, 200% of our appointments on mental health? That has to do with with cultural factors, lifestyle, the media, the internet. That has determined that our lives are fully focused on work, and we devote very little time to think on ourselves, on our own.
In my consultations, I ask the patients, what makes you happy? Tell me 3 things that make you feel happy. And it's very difficult because a lot of people don't know. They don't understand themselves. They don't give themselves that time. So being happy and being okay is something that requires an active work. It isn't something that just happens automatically without any effort on our half. We need to invest time in things that make us feel good. And when we identify those things that make us happy, which could be very simple things, we need to press play there, do it more often. That will make us feel better. Also, there's a provision for negative gaps. There's a study by the Ministry of Health, which is very interesting, that predicts that there will be important gaps in many medical specialties, and they will even greater in the next 30 years. So we don't have the possibility of thinking about mental health as the resort of just the specialist team. That isn't possible because they're as prevalent as high blood pressure and dyslipidemia. And so this is a need, and it seems to be a coherent strategy to strengthen primary healthcare teams that have a crucial team and a strategic role in this. We need to train them so they can recognize and they can evaluate the severity of mental health issues, so that those who do need a specialist team can have access to it, and others can have a follow-up and surveillance and controls in primary healthcare level. So inventing in primary healthcare means investing in promotion of healthcare and preventing suicide and treating for those families that would be affected by these problems. The projects by the Ministry of Health, there are several lines of work. Training is one of them. We are expecting to generate a virtual campus with the Ministry of Health virtual campus, which is focused on mental health. We hope people can do it at the time in which they need to do these courses. These courses are open and there's been a high demand for them, and that shows us the interest in the society to learn on these issues. Other projects which we are currently working on, and I can't explain all of them, but for example with primary healthcare, is related to the work in the assistential and care processes. We're looking at the processes which define seriously and supported by academia and multiple players to try and coordinate the demand and be able to degravitate things from the specialized system. We're going to try and work on producing several documents with public input, and we know that there is an important commitment on behalf of authorities, and we're trying to make these projects become a reality. Thank you very much.
Ahora sí. Bueno, muchas
Thank you very much, both of you, for your presentations. We are now going to begin sharing different experiences. The first one is from Barros Blancos, and looking at how we respond to a situation of violence by a professor from the Department of Family and Community Medicine.
Bueno, buen día.
Good morning, everyone. I also say it's a pleasure to share the experiences with my colleagues. This experience is relating to an integral service of protecting childhood and adolescents against violence. This has been incorporated in this panel because where there is violence, where there is suffering, it's very difficult for mental health to be developed adequately, if there are not to be problems regarding mental health of these people. So they may involve not only the child and adolescents, but the whole family context and extra-familial context as well. The creation of CPAV, which is this integral service for the protection of childhood adolescents against violence, is integrated by different central institutes. It's by the National Institute for Childhood in Uruguay. So INAO is the National Institute for Children and Adolescents of Uruguay. We have the Ministry of Social Development, the Ministry of Health, the Administration of National Public Education, and the State Public Health System, and it is coordinated by INAO. And this has an important impact on the different territories and the different institutions which are involved working in the territory. In Barros Blancos, we have the different institutions. We have INAO, we have the Ministry of Social Development, the municipalities development program, the University of the Republic through the Faculty of Medicine, and we have a health center there, and also public health, and also the Ministry of Education and the public education system through the different education centers, schools and high schools and kindergartens. That's our basic structure. The previous history before this in the city of Barros Blancos, we could see that there was a problem of healthcare problem because of this diagnosis of the situation. It was done by different healthcare teams and neighbors and the community. We were aware of the network that existed against fighting against violence. Ruta 8 is the highway or road that goes through this town. And from the Faculty of Medicine, between 2007 and 2009, there was a curricula of domestic violence as a health problem, and it was included in the curriculum of different courses which were taught at the faculty level. We are going to share our specific experience in Barros Blancos, in the CPF there. And for this to be successful and for it to be completely developed, there were several aspects that had an influence. The concept of decentralization for this work was very important to work in the territory. We had support from the town hall of the Department of Canelones, and we have a civic centre, and we have an important role there. That was part of the initiative of decentralization that began in 2005 to strengthen on the local level, the local government and local community groups, and also the interaction of different institutions on a local level. We had the university and the Faculty of Medicine. There was a decentralization in its second reform, and that included the Faculty of Medicine and the creation of the teaching units that work in primary healthcare level on in the territory. The presence of new programs of the Ministry of Social Development
Junto con esto,
that use the space of the Civic Centre. So this creates an interinstitutional approach, intersectorial approach, because there are sectors involved, social sector, education, the justice system, which I'm sorry I hadn't mentioned sooner, and we all come together working on a local level, and there is also interdisciplinarity, which is favoured and is possible because of this. I'd like to say that the only way of working on violence issues which are applicable to mental health is interdisciplinary and interprofessional. We cannot believe that we can do it on our own. Also, a very important, we mentioned already the Civic Centre, Salvador Allende. This Civic Centre it's part of the decentralization process, but we are very close, and in all the different institutions comes together these institutions that I mentioned. We have INAU is present there. It is close to a primary healthcare centre. This is a agreement with the Faculty of Medicine, the local government of Canelones, and the Ministry of Health and the Public Education, Public Health Service. And we have a training center there as well. So they all come together in this area, which is the Civic Center. And this enables all these coordinations and working as a team and a multidisciplinary team. Some enabling elements is the confluence of these institutions in the same physical space, the presence, a stable team. This hasn't been rotation of staff, but it's important that in territory there's a stable staff which can work on a medium, long-term way, because that way you can interact continuously. If not, it is very difficult to develop political policies. So we need to think as a together. Everyone needs to think conjointly in the territory. We had different stages for the creation of the CPAF in Barros Blancos. It began by developing teams in each of those institutions to coordinate and have a common goal based on the INAU's initial proposal. We wanted to sensitize, we needed to do workshops, dramatization, different presentations in local institutions and the public and private sector, and education system as well. We created a local reception committee. We received the situation, not any situation, generally it's situations which are the highest complexity, the most difficult management situations, and this implied training for the the technical team, we created the committee, we began to receive these situations, and we did a follow-up with the team. When we began to discuss one of these situations, we defined the strategy that is going to be followed, and then within that team there are two people in general who are responsible of following that situation specifically. Even if there's an exchange collectively, the follow-up and surveillance, which has different stages with family intervention and individual, and also including the interaction between the police and other people, the judicial and the justice system, and create the coordination. There's a specialist jury which is who deal with the situation, and that comes from this work on the regional committee that we have created in this area. We also contribute to the training. This isn't just a training of the problems, but we have teams, we have teachers, we have residents who are studying there, we have students, undergrad students, and then also home visits which are multidisciplinary. Some of the lessons learned. Just as I said, interdisciplinary work is possible because you can propose solution or contribute to an improvement in which children and adolescents are victims of violence. We need the view and the perspective of the different professionals working together in a specific territory who know the population, their culture and their community. That is one of the most effective tools for this kind of work. And we need to continue training our resources. Thank you very much. My time is up. Questions will be at the end.
Yes, questions and answers will be at the end. I know that we have very limited time, so I'd like to give the floor to everyone. And now the question is the implementation of this topic as part of public health. I think you have another microphone over there. It's implementation of the approach. Good morning. It's a pleasure to share with you this exchange of opinions.
Yo soy el doctor Daniel.
I'm Dr. Daniel Marquez. Mrs. Daniela Forice, a part of the specialized team in relation to the approach to sexual diversity. And let us tell you why we are in the mental health axis, understanding that mental health, precisely with this proposition related to the sexual diversity, is most important to focus on mental health because of things we're going to be saying later. Basically, to start thinking about the history of sexual diversity or the approach to sexual diversity in healthcare services, we are going to be talking about a time where there was no approach, when it wasn't discussed, to a way of approaching it from the pathology for many years until very soon. And the practice has its main preparation and the approach to sexual diversity since 2019, with many institutions participating and with many of the people in this room, and many of you participating here in this panel up front. So what we tried to do was to approach it as from the depathologization independent of the sexual characteristics of individuals. And it is from there that we've reinforced the positive impact of health care as a right. The institutions participating in this practice are Colectivo Ovejas Negras. I would like to highlight the participation of the civil society. Colectivo Ovejas Negras, like Black Sheep Collective organization, participated right from the beginning, from the very first initiative of free from homophobia healthcare centers until now. I would also like to highlight the School of Medicine of the University of the Republic. There were other very many schools, Santoral Rural, Canelo El Celeste, many other places where the School of Medicine participates. Also the School of Psychology, CASMO, which is a mutual fund healthcare institution focusing on the approach of sexual diversity. Then ACE in Pereira Rosell Hospital, which is a reference hospital. And there we have an interesting approach with family doctors and people in the territory. The approach of healthy people cannot be done through a hospital. Sexual orientation and sexual identity cannot be treated as a pathology in a hospital. That's where surgeries are carried out. But our work involves the reference of medical teams in the territory. Sexual diversity must be approached in the territory with reference teams. We are very emphatic about this because we think that it's very old to think about sexual diversity as a pathology. So we have to work with community teams in the territory. The municipality of Montevideo has also contributed. It's a landmark. We have worked together with the municipality of Montevideo and the UNFPA that has accompanied since the very beginning of against homophobia medical centers.
Vamos a ir pasando, en realidad.
We set up a presentation knowing that we won't be able to show it all because we are only given 5 minutes, but you can have access to it later on. Apart from CASMO, I form part of the Black Sheep Collective Union, and we are there since the very beginning, since I was a student and he was a resident. Of course, I'm much younger. But just to summarize things, this is what this practice does. We implemented some international recommendations, but along the road, we prepared our own guidelines at national and local level to try and see what the good practices should be for medical care from the standpoint of sexual diversity. Our focus is on the LGBTQ+, but anyway, we want better care for all the population and not only what we talk about LGBTQ+ community. This is what used to happen. There was no care among healthcare services. The link with mental health is more obvious in relation to the accompanying processes of coming out of the closet and accompanying not only the individual but also their family. As regards the conceptual framework, the social determinant of health, which in this case has to do with the stigma and the suffered than the question of delaying treatment, and people who form part of medical teams, they are pathologizing diagnosis on sexual diversity and sexual identity, as if the LGBTQ plus community was a disease. There's a new plan for mental health, and it refers to the deficit in professional training. We have worked on that because we have our entire leg of training in good practices, permanent services, courses that we have developed since 2013. We know it's a short leg, and we know that a leap forward is required for something more massive, or an attempt in 2017 from the Ministry of Public Health, providing courses for all the population, courses related to salary payments, including all this. But we need a more massive training because we've had a deficit for quite some time. The idea is to reduce the stigma and discrimination, and that has been stated since 2009 in the ministry's guidelines. Something else that we would like to tell you as an anecdote in these 12 years. We started with a practice 12 years ago where people were waiting for us as if they were requiring some clandestine care. You are the doctor, you are the nurse. I didn't want to make an appointment because they told me that if I looked at you informally, to a formal practice, to a formal manual that will appear. The second edition of that manual will be now issued soon, where we looked at sexual identity in childhood and adolescence. This is something that is pathologized a lot, and this is seen at very early stages. And then to live in the closet is an irreversible health problem, generating very big consequences in mental health. We would like to go over some landmarks, an overview of the process of public policies and sexual diversity in our laws on sexual diversity, and how that starts a dialogue with the practice. We only have laws at the beginning, but then little by little we have the implementation, the integrated health service, and the need to be accessible, inclusive, friendly. The first concepts that involve sexual diversity stem from that comprehensive medical system. We started in 2009, then in 2010 we started with we started working closely with the civil society and the residents and the chair of the school. And luckily, we had very many more services from the University of the Republic of Uruguay. And then we started courses. We had more laws making all this possible, that LGBTQ people, we exist and we have the right to have a happy life, to build our families. This is what many laws refer to. And all along these services in CRAM, in ACE, in the municipality of Montevideo, and at CASMO, that started in 2021. They all collaborated. And then the reference hospital, Pereira Rosell. The landmark is 2023, the latest landmark. And we went from what Daniel said, the semi or quasi-clandestine service and care, to move and institutionalized, something that is most important, that will always be very relative, the existence of social movements that will help us. But from the recommendations in the healthcare area, well, that is for the healthcare area in particular. The idea then is to close here. This is something that we will say. The impulse has continued thanks to the synergy of people and movements that started our places of action, but having very clear in mind that the implementation of this practice, not from a health provider in particular, but in the entire healthcare system, the UNFPA, the academia, the civil society have proven to be fundamental players. The problem is not sexual identity or sexual orientation. The problem is to live in a world that is heteronormative. Therefore, it's fundamental to have friendly services that are available in next service at PHC. Thank you.
We'll leave the questions to the end. Thank you very much. The last presentation is going to be regarding accessibility to the mental health services in primary healthcare, and it will be by our psychologist on the panel. Good afternoon, 12:02, so good afternoon everyone. First thing I'd like to say is that it's a pleasure for me to be able to share this panel and this living room nearly with everyone sharing, and we've been working along this all together for many years, and we want to improve access to healthcare for our population in our country. This makes me very happy to say hello to everyone and everyone in the room as well. There are people who have been together following us for many years. I'd like to share that perhaps this initiative of working institutionally between different centres, this has been considered with Ana Monza and the Centre of Nursing, who couldn't be here, institutional reason really, but we saw the opportunity for intervention, for access, not as an area of one single central centre, but also the territory of Surreno and Giordano, which are two healthcare centres which geographically are quite close by, and they share a lot of their population who comes between both these centres in this area. Perhaps this was our big initial question. How do we understand resolution in mental health in primary healthcare? This is a question that maybe you can think about as well for your services. How do we see resolution? And this is the initial question that we began to think, thinking on the resources that we had at that time and the availability of resources that we have today. Briefly, we began to think about this back in. We have three key elements and norms. We have the law of mental health that has been mentioned by Daniel and Flor earlier, the plan for mental health care, and the provision of services for mental health. And so in 2019, we realized that we were missing some treatments which were adequate for this service, which are related to psychotherapy, and there are private institutions that may be able to provide them. And so we began to explore different agreements to try and complement private and public sector I'm generous, maybe we're being ambitious with our practice, but we wanted to think in private services that would provide psychotherapy. We reached several agreements with different institutions in the private sector, and we were able to improve the access to certain treatments which depending on the objectives and the defined definite time. And it was a successful strategy, and we began to walk along this line of now we have these available resources for mental health, psychology and psychiatry, and we also began to incorporate strongly family medicine and community medicine as well. The pillars of our clinical practice have been person-centered. This has been considered in the integral national health system, but we went a step further and we said not only users and patients, but also the professionals and the territory. Every person should be at the center. What we mean by this is that the user to improve their accessibility to mental health resources, but also technical staff who are in the territory. They should all have everything they need to be able to resolve situation. This is perhaps debureaucratizing certain things. And have a more timely and earlier intervention. So if the person is seen 3 times in the service, you can lose the continuity of treatment. So if the technical person has an availability of doing these things, we cannot discontinue. These things that we shared initially of going for trying to eliminate the barriers between the two centres. This allowed us to think about an area of intervention which goes further than just ASE, which is the National Administration of Health Services. We wanted to create a integral healthcare and healthcare without a specific names to it, because that way we can give it a component which is conceptually trying to eliminate fragmentation of care and give attention to the population. Mental health and integral health has important connections, and that is also related to links and clinical management. And this process, what it implies is there's an area which is called a linking unit, and that's how our service works. The linking unit makes these connections between the different levels within the first primary healthcare level and with the other levels. So we have these linking units which work together with the technical professionals for the follow-up and care of these patients. Our staff has the possibility of accessing these different waiting stages. There's the demand, which is who is waiting to be seen. We want to improve this clinical management case per case and depend who needs to be prioritized and how we can resolve these situations. It isn't just a timeline, but based on the clinical situation, our professionals have the possibility of doing that. That implies visualizing the clinical assistance of the patients and what they need, and considering their experiences. And so our technical team, what they do is, do they have a physician of reference? If so, as well as their follow-up with mental health services, we also incorporate in this process the family doctors. We think that is key because, as you said earlier in the panel, the problems of mental health, if they're not considered in an integral manner, they begin to affect other areas of the human's health, and it's not manageable. There are different opportunities for training. And so we incorporated these programs of residents and interns of both the Faculty of Psychology and residents of the Faculty of Psychology, who focus not only on care but also in interdisciplinary and intersectorial management of mental health. An important thing that I would like to say is that perhaps how we link or unite all these different things. These things are all related. We have the privilege of sharing the last experiences, and you can say that perhaps these things that have been shared, they're all related. Firstly, I'd like to say two issues that are very important. On the one hand, decentralization. If there hadn't been a movement, organizationally speaking, to try and decentralize resources, we talk about human resources who work every day in primary healthcare. If that movement had not occurred, we wouldn't be here today saying a lot of these things. That is important to be highlighted because it makes this practical possible. And then also intersectorial experiences, they all have an important foundation on that pillar. And as we know, the public here, and thank you for choosing to be in this panel when there are several other options, I'm glad you chose to talk about mental health and say here there are people who we can probably identify people who are working in other organizations and they continuously and daily dialogue with us, and that wouldn't be possible, and that is another pillar if there wasn't this foundation of intersectorial work. And so we say it very easily, but then in the territory we need to build on intersectorial. We need to speak the same language, and those are historical issues and of course the work of many of you. Those two things are very important. And the third thing that I want to highlight is the issue related to all these small units that compose the process and the response to mental health services. We want to give space and give visibility to each one of those steps. And it's very exciting for us to be here today and speaking and sharing that you are here, and those of you who are part of each of those steps, because the linking unit, for example, is a specialized technical professional who is a key player in the follow-up and continuity of care of patients and the identification of timely need for mental health services. And the other point, when we talk about decentralization, we talk about a process in which each one of the centers that are involved in these areas, there are people who are specialized in a specific area of mental health that are included in those teams. And so those professionals who work in mental health have a double belonging to these teams and the mental health team overall. And that is very important for it to be to materialize the idea of mental health doesn't have a specific name, and that is our response and allows us to give us in a timely manner. Not everyone can receive care by a specialist in mental health, because when they are considered from this perspective, the special person in the doctor's office may not be a specialist in mental health. So there is something which needs to be considered, which is related to decentralization, and we'll see a graph at the end that shows us a little about this message. But beginning to think about our territory, as an area, it allows us for patients to see where they want to be seen, where they want their reference centre to be. We often found that the services should be done at the healthcare centres, and the clinic is one of the challenges that we decided to and we began to work on, and we've restructured with new resources, which was very good for us. It allowed us to kind of decentralize mental health services. This goes hand in hand with the specialty of psychiatry, but especially with certain specialties, this has improved access and timely interventions. We were convinced, we knew we needed to do that, but when we began to develop it, we had to choose where, when there is a management of calling the patient to tell them when they should come. There is also an opportunity for them to choose where they would like to be seen on the territory, and there is 2 places, and it includes 2 areas in Misurraco and Casabache. And this destigmatizes the population who have some sort of mental health issue. In Misurrago, it was a big challenge because they have a greater openness to mental health. But in Casabacha, it was quite challenging because it allowed us to see that professionals who are outside mental health, they began to see the possibilities for inclusion and integration of mental health in general healthcare. There are thousands of examples and stories, and one of the kickstarters for this was this opportunity to restructure the organization, but also we are very excited that we don't say these things, but from December 2020, the Center Misurraco doesn't have a psychiatrist for adults. It used to have 30 hours of psychiatry. It just had one day to the next. Suddenly there was no longer a psychiatrist. That obliged us to find a resolution in this network, in the primary healthcare network, and the implications that has. And that was what we had to do, is to creatively find a way, not wait to recover those 30 hours of psychiatry that we weren't assigned, that it wasn't our responsibility, but somehow this allowed us to develop new responses.
Exactly. As it happens, in view of the sudden lack of this, well, we have to take actions. Well, that's all. All right, you've already read the slide. We can discuss it together in the corridors. And then we'd like to share this photograph with you, this image. There. This graph has been taken from the Consultation Management Center, which is a corporate system for agendas, appointments, services. What we'd like to show you is that this isn't mental health, but the number of appointments and how this decentralization system from the center to the polyclinics and the psychology, increasing the portfolio and the availability, and integrated social work. What I mean by this is that many times we want them to have an agenda for interventions, and in fact we have a more cross-cutting agenda. We wanted to highlight this decentralization model. Last year would have been different. Important predominance of family health, and it's important to strengthen that access in the medical care team in PHC, introducing nursery because it hasn't broken down, and also psychology and social work. Thank you for the extra time. We'll return it somehow later on. Thank you.
Bueno, muchas gracias.
Thank you. Thank you all for sharing your experiences. Of course, you must all have much more to say, but we are limited in terms of time frames. So now you know the teams, and so it's important that you are in touch. The idea is to take up the challenges that were stated at the beginning. As you recall, they dealt with the difficulties of implementing this under the new mental health law in the integrated system, the trend to medicalize it, and the requirement that involves for psychiatrists, specialists, human resources training. Those are the fundamental axes. The floor is open to the colleagues and that are here.
Por favor, decir también si la pregunta es general o si está dirigido a alguno de los compañeros que están sentados aquí.
I can't hear the question if there's no microphone, please.
Lo otro.
Okay. When we talk about introducing nurses in this, training in the trans community, to say it in short, are we also talking about training nurse assistants? Because I remember that the first time as a nurse assistant, a man dressed as a woman. This was a long, long time ago, before all this. I said, well, how can I digest this? Because I didn't know what to do. And then, since I hadn't been trained, I started learning with the person himself. Could you tell me this or tell me that? And I started learning. So for the benefit of the users coming in, and for the benefit of the assistant nurses, are they being trained as well? Yes, precisely. The wealth. I'm sorry, I haven't got a microphone. Very briefly, the wealth of the courses that several institutions are providing. I think it's course number 11. We have been giving these courses for 11 years. The wealth is that they are interdisciplinary. There are assistant nurses. There are several schools of medicine. The enrichment of all this is that there are many institutions involved. And there is something else. There is a lack in training that we haven't been able to focus on, because at present, assistant nurse trainers or trainees and training lies with the private sector. So the way we've reached them, and the main articulator of this has been the University of the Republic of Uruguay, which isn't training assistant nurses. That's horrible. That's a problem, because that's the majority, the large majority of the workforce. What we're trying to do is that right from the outset, include the entire medical team, independent of their functions, because we understand that they promote health, particularly assistant nurses, because they are there close to patients, and also training in services. We have done this in all services. I recall in the old city here in Montevideo, when we started we did it only with assistant nurses because there is a lot at stake there, and that's what I wanted to share with you and mention here.
Buenos días.
Good morning. Rather than a question, I've got a comment. I come from Durazno, one of the provinces of Uruguay, and I belong to an institution called SNIS. All the presentations are with from ASE and all the conventions, but when you come out from the metropolitan area, the reality is different. We have over 60,000 people in Durazno. There are only 2 positions, 2 people who live in the province as psychiatrists. They were appointed of high dedication by ASE, and this means that if you have a high dedication position, you can't have multiple jobs. This has to do with the position, the salary, and the enormous increase that you have at ministerial level. We entered into a management contract. We form part of SNIS, and we must comply with that management contract. That's a way of funding, complying the goals and the work. We have new areas for work in mental health with 2 shared resources. 2 people from Durazno. There are only 2 who can do that. The other large problem is that institutions, health provider institutions, are covering deficits from other institutions, just as the judiciary, for example, that hasn't got any forensic psychiatrist, and ask health providers to make judicial reports every single day at any time of the day. Even if you have on-duty psychiatrists. So I have residents coming to my institutions to be on duty over the weekend, but since they haven't got their degrees, they can't make any reports because they're not psychiatrists. So the solution of residents isn't something that can help us out. This isn't possible. Sexual abuse, on weekends is when we get all the claims are filed over the weekends. So we have to refer patients 163 kilometers away from Montevideo. Sometimes, instead of being hospitalized in Durazno, where their families are 2 blocks away, they are hospitalized in Montevideo, 160 kilometers away. So the bottom line here is that we have a reality. We have a lack of positions. The ministerial strategy of training primary health care specialists in mental health, we think it's good. If someone wants an appointment with a psychiatrist, it should be a psychiatrist, and that is seen as a claim because patients have a long time to wait for the appointment. So we institutions, because of the lack of trained human resources, well accredited, can ask them to work. The other thing has to do with foreigners. Our reality shows that we have many foreign professionals holding their own degrees, but they have to revalidate their courses. For a GP, they will revalidate their diplomas in 3 days. But for the rest, if they can't revalidate it in 3 months, they can't work. And so after 6 months, we can't renew the contracts because they haven't been authorized by the ministry. So that's a reality that involves the territory, and perhaps the presentations made here did not consider that. Thank you very much.
Hola, buenos días.
Good morning. Let me stand up so you can see me. My name is Viviane Dufault. I am a sexologist, sexual therapist. I am magister. I'm giving you my CV because I'm the sexual coordinator of AXE in place since 2018. We depend on Pasteur Hospital, but we are in an annex behind the polyclinic, and we've been there since we've been working since 2018. I would like to tell you, because in that chronology that you showed in the diversity, because you didn't know, there is another service that, although it doesn't appear as a care to sexual diversity, but sexual health, and this is where we get all assay users with some kind of disorder or problems and sexual issues. We had to get updated and reorganized in care, in accompanying transitions and all that. And it would be very good if we could work together. I am talking to you too. It would be good to work together. And I would like to share this initiative with you in order to have a broader scope. We are on the other side of the city, so it would be good. Thank you.
Bueno, yo
Firstly, I'd like to congratulate you all because your presentations have been very clear and very with a teaching perspective. I'd like to share my vision and my contribution of how I see this. Why did I come to this panel today? I chose it because I thought this is what the future. We see this as something which is universal, but we do not know how to go about it. How do we apply this? I don't present myself. I am a department director for Paysandú, a region in Uruguay, and you said this doesn't have a name and surname, but it does have something which is very important, and I'd like to highlight this. It does have to have leadership and coordination. And where is the leadership and the coordination? Firstly, it should be in the political power who has the desire and the priority, and it has something that this country has which is very important, and that is democracy. And here it doesn't matter who is governing at the time, but all of us who work in healthcare, we should try and comply what is ordered by the political power of the time, despite this, whoever's in power at that time. And that has led to Uruguay, and you know this, a colleague from Spain said this earlier, and that's the difference that we have with other countries, and which is why we have progressed. We often say that our country doesn't have certain health policies in general. This country does have politics, and it does have certain policies, and that is the democracy that we see in Uruguay, and everyone tries to fulfill that. So this is very important because the government who's in power at the time it sees it as important and is prioritizing this. The other important thing that I believe, and this is my contribution, is that those who should act as coordinators, the best coordinator we can have is the Ministry of Health. What role should Dr. say? We should align general conditions which are applicable to everyone, because we need to fulfill those commitments. And the department directors of the Ministry of Health, we know the territory, and that intersectoriality that you highlighted, and you said it from your perspective each, we know how to coordinate. The department director, the Ministry of Health, and the different strategies which are proposed from above, we really should bring that team together, generate the intersectoriality, and that should be coordinated by those who know the territory and know the people who are ideal for the job. So even though we know this is challenging, and the colleague shared that, it's not the same to be in Montevideo or being in Artigas in the north or in another area of the country. We, the directors, and all who are following the steps, who is the minister and who is coordinating mental health in the Ministry of Health, we know these steps aren't easy, but we should follow them. And as we are all aware, it is very necessary, and it doesn't have to be the psychiatrist. We need to have the ability and the innovation and the ability to create new resources which will support and which are very needed in primary healthcare. That is my contribution. We have policies, we have norms, and we have a Ministry of Health with someone who understands the value, who knows where the key points she knows she can support, and so we can really take this to the practice. That's my contribution. Thank you.
¿Cómo es?
Sorry, what was your name? Carlos. In response to what you were sharing, next to you we have Andres Montaña, who's someone who lately we've been working closely with on a local level in Rio Negro, with an experience which is has been very interesting. And this shares what you've been experiencing. We completely agree. Perhaps good practices are related to decision making on a local level. But of course, what you mentioned about leadership and decision making is very important. We need the support. Gonzalo mentioned it at the beginning. It needs to be supported by the legal framework, and everything that we shared is in this within this framework, and the good practices and protocols that and plans that have been established. And we cannot not deny their incredible value. And of course, in decision making on a national level regarding the importance of mental health, but also in providing these resources financially to be able to maintain this over time. We are totally agree with what you shared. Thank you. Thank you, Dr. Leon. I'd like to say we are working on this. We are working on tools that will organize and take away the pressure of the specialist recourse, and we're looking at training resources. These documents are in early stages, but hopefully they will be united. Thank you. Hello. Good afternoon, everyone. My name is Olivia. I'm talking from the Ministry of Health of Brazil. I need to speak in Portuguese because my Spanish isn't very good, and I will try to speak slowly so you understand me. In the Brazilian Ministry of Health, we have a multi-professional team in primary health. These are teams that have a possibility of having about 22 professionals, and the manager of the municipality determines the need of the team on the territory. So the professionals will depend on the territory. So psychology is one of the first two which are requested most frequently. We may have around 8,000 psychologists in primary healthcare. We also have a lot of social workers. Physiotherapists, nutritionists are also chosen quite often. I'd like to highlight that, as you said, the importance of a reference team and the strategy are based on the family. And we have the same similar challenges, and we're working with the same line. We need to continue to work along these lines. I'd like to share a challenge which is very great that we have in Brazil, and perhaps it's also a challenge for you. Our professionals often work in integrating and professionals, and the groups are often done in this sense. And we are providing we have to attend a lot of consultations, and so this may be a conflict between the truth that we see and the experience that we have seen already, but also the pressure of a number of consultations, the demand that there is. And that is a pressure and generates conflict, and we need to live between that balance. I'd like to know if you also have to deal with this situation. Thank you for your question. Yes, of course, this is an issue, and Carlos also mentioned it very briefly. In the system in general, we have to deal with long waiting lists, long lists. And so for us, this change of a conceptual change of a waiting list and the opportunity for intervention based on a clinical analysis of that waiting list, and we call it the demand, which is in line or waiting. And this is the process which may be more specific, and we'll share this. The technician or the technical partner who is analyzing each person's situation, who is waiting for a consultation, often the psychiatrist isn't not only waiting to deciding if they're going to take that consultation or provide that consultation. It's also other colleagues can make decisions about how the process can continue. Of course, there's got to be a discussion with the coordination of mental health and the whole team, this interdisciplinary team, but we can take this decision of how the process follows, and it doesn't necessarily, Carlos was mentioning it, that it isn't only the vision of psychology or psychiatry, because we're never going to have enough with the professionals that we have. As I was saying to Flor, is we're going to be demanding a psychologist and a psychiatrist per person who for the number of people you're attending in that area. And that's impossible. So in this sense, we have been able to, those people who just have been only had mental health consultations, they'll have more integral look, and then they can spread out their consultations in mental health services, but adjust medications, and this challenge, which is often difficult to try and work in other areas of healthcare or of well-being, which aren't only the biomedical and more intersectorial. For this that you mentioned, which is this pressure of everyday clinical practice, we have a phrase in our center, which is the response in mental health isn't just providing an appointment. That isn't providing a response. We'll never be able to give it in a timely way. It won't be timely. And so the response for mental health for us in our services is to be able to see the person at the center and see all their historical attendance in clinical services, whether it's their reference physician, if they have a family doctor, if it's more convenient for them to go to another center, who are they more comfortable with? And those are the questions that also are part of the response. And the last step may be the appointment with the specialist, but you need that time is also sustaining and supporting the pressures, which aren't only related to the organization or the patient, because as the colleague said, it's also there's this culture of demanding specialty consultations, but our colleagues also need to see and this with concern, but be able to respond to these needs when we see them and see that this person is concerning. We need to have an availability of time and not have too many appointments in the agenda to try and give a response without really integral thinking of the response and of the person. And the other thing, I think that analysis of analyzing the demand has allowed us to generate group intervention that can be very therapeutic or for working, and for those who need a differential attention due to the situation that they may be living and experiences. I could think of many examples, but we won't so go into them. Hello, good afternoon. I would like to add, I am a psychologist in the territory. I work in the Center Giordano. I am aware of these good practices and the good benefits they have provided our patients and users. This integration of mental health to the network of primary health care and the possibility of working directly with a team and especially with the family physicians. This has been an excellent move. I just wanted to congratulate and just say, for those of you who know me, I'm going to talk about institutional racism, because this is a perspective, an ethnical and racial perspective, which needs to be integrated into care, because into the institutionality, because if we are not doing that, we're committing an omission. The states and nations, and Uruguay isn't an exception. I'll speak of Latin America. We have a lot of Afro-descendant population. There is a everyday racism which is present, and health services and also racism causes disease. For very avoidable issues, if we had a clinical practices which fight racism, and that will be given to us from a perspective of intersectionality. We have seen gender, we have seen class, and the policies for decentralization work towards improving those things of taking the services to where the people live and those sectors where the demand is. And those sectors often are very vulnerable. And race is another variable which is impacting the person's condition in any sense. So considering people from that reality and that perspective makes a difference. In Giordano, we had a approach considering working with the team to be able to see that the person that you have before them may have been racialized and destigmatized and has many experiences due to racial violence.
Therefore, for me, for the collective associations to which I belong, I'm also at ASE and at the School of Medicine. We are available resources. There is enough research work. And for example, ASE and all the public services should introduce the ethnic and racial variable in the surveys of in the data surveys. Why are we separated? Because there is daily racism. The capacity to do that is in the hands of the people who do that. They have the capacity to include that data in the IT system. And then the people who have to ask the question, and I have to understand why I have to ask the question. And if I have any difficulties or drawbacks to do that, we have to go over our own idea of racism, not understanding when I'm not asking that, I'm not ensuring a right. I have to find out why it makes me feel uneasy. Sometimes we have to think about it, to survey it, and to have minimum data. Without minimum data, we can't do true policies. We all know that. I wanted to share this with you. This topic is never on the agenda. We Afro-descendant, Afro-Black have the need to table this so that everyone from our own places should see how the person we have in front of us has, as the colleague said, the problem is not of our descendants, the problem is of whiteness that starts being placed as the only valid paradigm. This is one further contribution. Thank you.
Buenos días. Mi nombre es Jocelyn.
My name is Jocelyn Otegi. I'm an assistant professor and psychologist and a colleague of many of you up front. Before anything else, I'd like to celebrate these meetings. I was sharing these thoughts with younger colleagues to hear this name of family and community medicine is incredible for some of us who have been here for a while. It's progress, it's advance. And when we hear about the expectations about us regarding mental health, makes me feel a bit afraid. We discussed that with Alejandra in that seedling work we're trying to organize mental health care in the places where people live. And I would like to make 2 points here. That sometimes when we talk about these programs, we automatically think about the public subsector and we leave outside the private subsector. And this is because the presence of these strategies that we think means to resort to family and community doctors is a bit more scarce in the private subsector. And that's something that we owe to the program, because a national program focusing on basing itself in the presence of these resources, when they are not, it's quite unlikely that it can be carried out successfully, at least in that area. On the other hand, as regards the contents of our specialty, mental health has always formed part of it, and it always forms part of the way we do medicine and understand medicine. And perhaps what we're talking about here is not only thinking about mental health supported on family doctors as a support focal specialized teams, which is also important. And we have to train them as well to be more skillful. But we also have to strengthen family medicine as a key first level medicine. Because I was listening to all of you. I can hear you, that you speak from your hearts and the passion that you put in it. I can hear the colleague talking about negritude, and I can see her speaking from the bottom of her heart. I have to talk about family medicine, but we have been strengthened and we have had the possibility of being supported by focal specialists. But we have to develop family medicine because caring for mental health is caring for a comprehensive health, and we are specialists in that.
Hola, buen día.
Good morning. I'm Leticia Villasbo. I'm also a family doctor. Taking up what Jocelyn said and what Ana Karina said, the fact that mental health care means comprehensive medical care. And I was thinking about social determinants of health, where the ethnical, racial, and gender are structural medical determinants and social determinants. And the question of integrating a gender outlook and a ethnic and racial outlook is fundamental. But I think it's most important to be able to talk to work with other sectors of the population, with other institutions of the population that lately have been done away with because they used to have a territorial anchor. We lost the nodes, the SOCA. Many interaction instances that allowed us to approach problems of health as anything that could involve the health of people. I think that to talk about mental health, we have to think about a non-political perspective. This is political and this is management. And to look at health services, I want to talk about the time we are given per consultation. I'm not talking about any provider in particular, but there are places where patients are granted 6 minutes. So how can we talk about the integral mental health of an individual in that time? So when I say it's political, I say we have to work on those concepts. What's the vision of health providers, of the type of care that we have to provide? Because that leads up to our own mental health, because this means overload, this means burnout. And I think that we have to think about all these matters. Also thinking about programs of public policies, it calls my attention that there is a program that is being carried out, and I don't know much about the content of the program. Is called Strong Families. Its director expresses himself in the social networks against pregnancy and about, I wonder what the imprint of that program, when in fact what they want to do is to work on problematic addiction. And I wonder what the position of the director is. So I go back to public policy and to mental health, adopting it as a what's the approach from the political area to approach mental health? That would be the question.
Muy brevemente, digo, retomando lo que...
Very briefly, taking up what our colleague said about leadership and rectorship, we fully agree. From the institutions and from those who are in a position to make decisions, we have to see how resources are allocated, because we have been losing resources at territorial level at primary health care in the past few years in different institutions, both at private and public level. All this has been reduced, and everything that we are sharing here is becoming more and more difficult to carry out if we don't have enough resources, or if resources are being reduced. From the rectorship, and those who are able to make these decisions should take into account. We can't carry out territorial policies to approach the comprehensive health of people or mental health if we can't move forward taking that into account. I'm taking up what the colleague from Durano said, the difficulties with human resources. This is also at private level. In the pandemic or post-pandemic times, the primary health care has been restrained. And I'm saying this as a concept. The leadership of the rectorship should point that out. That is how to recover at least part of it. Thank you all. I have asked my colleague to give the closing remarks. I would like to conclude with two ideas. The questions have described them very well, and that's the challenges that we have in governance. That is how we can move forward towards a community-based service. And we have to rescue the complexity of governance, because there are several components involved. We link governance to standards, general frameworks, macro management, in the case of Uruguay, mental health law. Now, everything's been described here has to do with strengthening governance, translating that into the fact that governance is not a structure in macro management, as described by Dr. Leone very well. There must be a structure going down to the social issue, and that involves a challenge for leadership at different levels. We need leaders at macro management that are truly leading the change, and we also mean leaders in meso management and in local teams. So all this is generating a structure of the system that is truly moving the change. Another important and main element described by our colleague has to do with financing mechanisms, where are incentives, and what happens is what's just described. Sometimes we have a design that is wonderful in terms of mental health policy, of what we've talked about, how the system should be organized, how we can have a more complex network organized according to their complexity and seriousness level, accompanying people. But when we look at incentives, well, incentives are in individual care, in coverage, and to have a comprehensive model. There are services that are not along that line. Whenever we need a home visit, when we have to know the territory to make a good diagnosis, that appointments should take 2 hours, and that's expensive in between inverted commas, but it's necessary to have managed models that show the change in the model, but that on the other hand, at the level of basket and provisions, we can have provisions providing a comprehensive care, and that's linked to payment mechanisms that should also be coherent to promote the final implementation of medical teams in comprehensive mental health care. As regards the challenges that our colleagues mentioned, and our colleagues describe it very well, how stigma, discrimination, exclusion are also increasing the risk for people to fall ill. I would like to say that this question of having a community-based and PHC-based network, well, the main thing is not that it should be at a lower cost, but that it should be coherent with the prevalences that we have in mental health. The larger number of people that will be ill with common mental health disorders, and that may be dealt with in PHC. And the challenge is that those people don't become worse, can recover in their communities, can have their own personal resources for their recovery. So the change of model has to do with the gap challenges that we have, which are gigantic, but it also has to do with the most timely and more efficient response, creating less stigma in the population that allows us to have to get quicker to the more marginalized communities, that allows us to take care of mental health as part of the comprehensive health care of all individuals. Thank you all. If you want to scan the QR code for a survey, which is anonymous and confidential, and that will give us a lot of information, we should be very welcome. Thank you, and thank you all for having participated in this panel. Thank you.
No, yo no sé qué les parece, como ustedes quieran.
Es como más familiar.
Cuando me toque a mí, me cambio yo.
Claro. No, la idea es, ¿les parece así? Nos quedamos acá.
Ahí el coso.
No, es importante que tenemos. Entonces, nos vamos a ir pasando el micrófono. Acá, primero está. Bueno, muy buenas tardes.
Good afternoon, everyone. We are going to begin this panel about management of social and environmental determinants of health through community work. We want to reflect and generate dialogue between us all. We plan to exchange opinions on these social determinants of health. We all are aware that health isn't determined only by biological factors or those related to social services and health services, but it is determined by a complex network of social and environmental determinants that must be managed in an integral manner. In aiming to create a more just and equitative environment and society, we need to influence in these determinants that influence people's health. Primary health care is our compass in this journey. We hope to bring health care to the heart of our communities. And how do we do this? The answer is in intersectoriality, collaboration, and working together between different sectors, because healthcare isn't built only through health services, but in a specific context of intersection between education, work, housing, access to food, culture, relationships, family, and everyday life of everyone. Community participation is a key pillar in this strategy because health is built with people. The voice of the communities must be heard and respected for conjoint decision-making which impacts their well-being. We need to strengthen the spaces of participation to guarantee that all voices have a place and decisions are made together considering the specific needs of each group. Empowerment is a transformative power. We need to work to empower our communities and give them the tools and resources that are needed to take control of their own health. This implies education, access to relevant information, and promotion of activities for each individual to make informed decisions regarding their health. In considering this framework, I invite you to share this panel and hear the challenges and practices and experiences. Welcome to all participants and all panelists. As an initial framework, we want to reflect on a few aspects, the good practices in primary healthcare, which show that intersectorial actions with a community work and a social impact, they are key to determine changes from the determinant social and environmental aspects. But we have certain challenges ahead of us. Sometimes managers have difficulties to generate integration in these health in the community area. In some occasions, we don't manage to achieve synergy between managers and those acting, and they are trying to improve the society they work with health. And finally, professionals in their training receive few elements to develop specific capacities for building in community environments and to respond to its complexities. We invite you, and now invite Pablo Anzalone, who belongs to the Red of Municipalities and Healthy Communities. Pablo Anzalone is a researcher about social participation in the National Integrated Health System. He's a member of the Social Association of Healthy Communities and teaches sociology at the university in the University de la República and has a postgraduate degree from the University of Coimbra. It is clear that this is one of the key aspects of any process when we think about primary healthcare, to step away from a mercantilized, fragmented model. We want to step away from that model and build a new one, and it is important to act on these social determinants. And part of that access comes from social and community work. Of course, you need national policies and regional policies that look at these issues. None of these issues are going to only resolve on a local level, but those issues that impact quality of life and climate change. But the importance of community is essential for the organization and social participation. To manage to get the community is a key character and main player, and have to give their approval and be involved as a social construction of health. In this sense, considering the national integrated system of health, primary healthcare is at the basis, and social work is involved, and there are many actions that come from the social context and the social system, and it has been built over the years. And after this design, an example which is very important in Uruguay is the social provision bank. It is the social security system here in Uruguay, and there is the experience that we have from the municipality of Montevideo, and giving healthcare, providing healthcare from the community, and it comes from the different social groups. On the other hand, it's also important to consider for the national system, there needs to be a participation at the top. We have an important participation of workers and retirees in the directorate of the Social Provisional Bank in Uruguay. So social participation is involved in all the different departments of healthcare in Uruguay, the different committees and commissions. It's very important for this design. The implementation is more complex. There have been some very positive experience in some areas and generating new experience, but in other cases there have been great obstacles and barriers, automatic pilot and difficulties to move forward, problems for this implementation of a democratized implementation with an integrated approach and consideration of healthcare. So I would like to mention a few things that need to be done. One is what we're doing here. We need to learn from highlighted experience. We need to visualize them, give visibility to them, and promote training for action. We need to research and these issues. It is important to learn and share experiences and reflect on them. I think that is key for any process. That's why I want to highlight this. The other aspect is the fact that in Uruguay, in around 2017, we did a process for training from the union workers syndicate. We organized different courses and that generated a social front in healthcare, and that generated several programs that were presented to the Ministry of Health, and after 10 years after the implementation of the National Integrated Healthcare Services. The proposals that were presented were now this year were reconfirmed by all the social organizations that were part of that initial agreement, and they consider they are still pertinent today. And they have, some of them, the problems that were considered at that time have even become worse. One of those processes is how to strengthen from the territory an integrated view with a participative diagnosis, an elaboration of local plans, accountability to the community of what has been done and what is being done. And this isn't just a theoretical process. This has been done in many places. It has been done in several networks in Montevideo. They've been working for several years with that direction, and they defined the priorities and then had an accountability situation. And I think that's important to learn from that. We also need to consider that there is a structure on the social part. This can be organized and it isn't isolated from the system or the political aspect. No, the social aspect has its own network. There are alliances, there are agreements, there are challenges, but there are also achievements to build synergy between and consider the complexity of these problems. The other aspect which I wish to share is the experience which we have from 2019-2020 with a network between municipalities and healthy communities. This began in 1996. We'd already mentioned about healthy communities supported by PAHO and developed in away from Montevideo. But we began this in the Municipality A of Montevideo. We decided we need to work in a network. It couldn't be isolated projects and just related to the Ministry of Health. It was important to learn to work together, and we planned to begin this network on the 20th of March, but on the 13th of March, emergency was declared epidemiological emergency, and everything was done in a virtual manner, but there were many meetings.
And the idea was to have an overall approach to mental health, relations, the role of healthcare in the pandemic, to deal together with the academia, with the public policy makers and the social players, having participation and feedback, that is a participatory dynamic in pandemic and isolation conditions. It continued in 2021 and 22, and in 2023 we were able to hold the Pablo Carlevaro Congress. The idea was to have a social participation. We had 7 preparatory conferences from Atlántida to Bella Unión, Paysandú, Canelones, Montevideo. These are different provinces of Uruguay. There's an interesting experience to think about it at global level in our country, and to think about a decentralized organization where the academia and those related to each one of the topics, mental health, the elderly, childhood, adolescence, could participate actively. And this is because the participatory diagnosis and to have national health goals that Uruguay has started has been doing since 2015 and has renewed them now. So apart from the national health goals at country level, we need them local. We need local ones where the voice of the communities in the territories are taken into account and are reasons for engagements. And not only because they have a common ground regarding financing. It's important to have common financing, and it's clear that FONASA in Uruguay has played a fundamental role for sustainability and for the development of the system as such. But that isn't enough. We can't have a group of fragmented sectors. We have to work in a network, working towards a common and coordinated goal. And experiences that have been carried out have been very enriching for health policies. And all these are steps towards in a process that is complex. Not everything is downhill, but it's important to think about health as a social construction and not only health provision in case of illnesses and diseases. This is very much related to social participation, territories, and the way health policies are organized in the territories. Thank you.
Excelente, Pablo. Muchísimas gracias. Y le damos la palabra.
Excellent, Pablo. We're now going to give the floor to Dr. Andrés Montaño with his outlook from the Department of Health of Rio Negro. Thank you, everyone, and thank you for this invitation. When the health authority determines health action, that action must be landed in a certain territory. Our outlook as a rector of the provincial health of Rio Negro is that general plan is landed in a geography and social participation that involves cultural and demographic issues.
Muy efectivas. Yo diría que son.
They are essential to be able to have an influence on social, environmental, and cultural phenomena. We have certain examples in our province together with PAHO, a program to implement mental health in our province, and another one which is a plan for suicide prevention. We have done a lot of work about it. To that end, we've done an exercise, as well as the teams working with us, to identify the strengths and weaknesses for a participatory project.
La opinión de todos los actores.
A project that could gather the opinion of all social players. However, we have to know the demographic and population characteristics of the project because many times projects don't coincide with the reality, with the cultural and economic situation of a province that may be different from another one somewhere else in our country. We need to give the true dimension of the characteristics of the demand that we have to implement. We must analyze the various factors at stake. And we have to believe as chess players, looking at the movement and the action from all standpoints possible. And we have to look at how feasible it is in our community, because they may not be of an interest, or even if important, perhaps the community doesn't receive it as it should to be able to be effective in the community. As regards the second question, or the second challenge, rather, well, managers have difficulties to integrate health agents, teams specialized in the subject matter. Sometimes it's the lack of teams, not only training teams, but the question of having teams to work in a territory. And sometimes is the type of training that the teams received. They don't have the necessary skills. We must work on that to provide them with those trainings. As the regional forum stated it yesterday, health events must develop, must be solved, or may be solved up to 90% in the primary health care level. But there is something else that was mentioned yesterday as well, and it's organized by the demand of second-level places, hospitals, because many times we can see that consultation at a second level is anarchic, disordered, and it even generates a change of mood when doctors have to deal with certain affections that could have been solved at the first primary healthcare level. And sometimes managers don't have this clear. They don't understand what's happening in the community, and they can't measure the impact caused by the daily life, the role played by the rectorship in the territory, such as the one we practice, is to harmonize and reduce that distance, acting as a catalyzer, trying to get the parties together.
También fue dicho ayer.
It was also said yesterday, the investment in health is made at the second and third level. Health providers look at hospitals, high-resolution centers, and they don't look at how beneficial it could be to make investments at primary healthcare level. They don't see how useful that healthcare could be and their benefits. There is also a distance between the role of the manager and the community agent. They don't have their roles very well defined, so the rectorship tries to make that link more official, highlighting the impact of a project in the social tissue and the social networks that we are working with. We're trying to introduce in provincial strategies or local groups of a territorial action. Sometimes we fail when we think about PHC, and we only think about the capital of the province instead of thinking of more remote places where there are a group of 10 or 100 people who also need health care. So each one of us, taking into account our strengths and weaknesses, must look for our own particular strategies, personalized in each province, whose main objective is to build a work line, generating representative actions among those involved, that it is a participatory construction to look at the territory involving everyone, that it's a collective construction. Lastly, we must use a strategy to raise awareness among the professionals, to make the actions in the community as a general to generate a higher impact in the generation of a project. This is done through talks, workshops, exchange groups. We must act in the academic training as well, in trying to do teamwork, to deal with leaderships which sometimes are so difficult to face. We have to look into the weak points, how to settle disputes, how to establish competences. The rectorship must have all this very clear in mind so that we can get to the right goal. We try to envisage all this not only from the health standpoint, but from a more inclusive standpoint, including economic, social, cultural, environmental issues that change from one place to the other. And let me conclude with a good piece of news. This year, UDELAR, the University of the Republic of Uruguay, that has a northern headquarters, the first doctors will graduate, as well as the first psychologists fully trained in the up country, in the north of our country. And they have very clear in mind the concept of PhD. Right from the beginning of their courses, they start working in peripheral medical centers, clinical centers, and neighborhoods in order to be well trained in PhD. Thank you.
Bueno, muchísimas.
Thank you very much, Dr. Andres Montaño. We are now going to hear of the practices, the good practices really, that have been selected and which are related to the management of social determinants. We would like Dr. Marcela Cuadrado.
Ahora sí, saludo.
Okay, now we're ready. Thank you. Good afternoon, everyone. It is a pleasure for me to be here in this panel with people who have been here for quite some time, with people that are in this forum, and it's been fantastic from day one, and we're learning a lot about primary healthcare. At this time, I come to share with you some activities that are taking place in the community of San Bautista in Canelones, the municipality of San Bautista. Just so you can locate it on the map, that is the map of Uruguay. And San Bautista is halfway up the department of Canelones. It's a small town which has 4,000 inhabitants. 2,000 live in the urban center and 2,000 live in rural areas. This is a collaborative project which begins in the National Health Center clinic. It begins in 2007, and then there is a time where the project was run out of funding, and we had to pick it up again in 2018 with an investment that we had from the public health system, and there we were able to pick up that again. This is a project that is developed along with the Faculty of Medicine and the ASE, and also with the education system, because we involve rural schools, and so the project extends to also the Ministry of Agriculture and Farming, the Town Hall of Canelones and local government. So the project has continued to grow. What are the facilitating elements of this project? When we began to work in San Bautista in year 2005, the team that was working there with the nurse and other doctors and colleagues and administrative staff, what we saw is that there were a lot of women who would come to our clinic and the doctor's visit, mainly to do with the problems related to their children, their parents, their siblings, but they would not express it directly, implicitly in the clinic. They would say the explicit things, but the implicit elements were not mentioned. There were a lot of lack of opportunities for women in the rural areas, especially those women. They represent an important percentage. Around 50,000 women in the country represent women in rural areas. And of these women, few of them have opportunities at this time related to access to different things, especially health services. In Canelones, it's slightly better because the distance to Montevideo is shorter. But we realized there was a need for a space of a meeting space for women. The men would go to the bars or pubs, but the women, a lot of the time, stay at home. And so there was a need for a space, a meeting space for women, and the lack of that led to social distancing and isolation, and it would generate certain problems such as anxiety, depression, and insomnia. So what we found is that from clinical practice, what women were sharing as a problem, we developed this program, which implied developing this meeting space. When we received the funding, we were able to do that. And we did it outside the clinic area, and it was done more in a rural area and using a rural school. We invited women and they began to participate and shared this need. And over time, this space has been seen as a healing space that they have really taken and created and become their own. Here are some of the photos. Those are two residents of family medicine. Here is a photo that we also shared in this meeting space that we have. What has been the impact of this group after so many years working with them? We began to work, as I said, back in 2008, 2007, 2008. Then there was a group that began again in 2011. 2011, we had a financed project which was funded. We brought other proposals for issues to be worked on and workshops. And women decided to continue. They made it their own. This project is no longer funded, but the project continues every year. It has been uninterrupted over the years. And even in the pandemic, we continued to meet virtually. We did a lot of activities online, but when we wanted to return to community activities, they decided that we needed to improve the projects. And I always said we continued to meet under the table, so to say. We'd meet outside of our working hours and things. We defended this place as an important space for women. It was needed by these women. It had its properties of healing properties for them, in a sense. Currently, we have a strong group of women who have a strong rural identity, and they are proud of being rural women. And when we began to work with them, there was an important feeling where they didn't feel intelligent, they felt abandoned, they felt that they had a different culture, and that they weren't worthy of being there. But today they have their own initiatives, they have a self-managed and solid group. This is a photo in the legislative office here in Montevideo, because they couldn't have property rights of lands due to ancient laws. And so in 2019 we began to work and challenge the law of colonization, so women can have what's called colonists here in Uruguay, and they can begin to do different works and different jobs and have their own rights. So this began from the national health system, but it is an intersectorial project. From 2009 onwards, it began in San Juan Bautista, and they have a important day. It's a 15th of October. We share. It's a festive day where they annually get together, over 150 women annually, and they celebrate, and it's organized by the municipality of Canelones. And a lot of these women, in 2016, we produced a woman, which means a look inwards, and in Uruguay, el interior is inwards, is also the upcountry outside of Montevideo. And so it shares experiences of rural women and experiences and issues that are important, like being mothers and learning forgiveness, domestic violence, prevention of health and promotion of health and all these different issues. This is the book in 2016. And the impact, the experience has been shared, and these women have also wanted in some way to form specific women's groups in other places. This was an experience that at some point was also the office of government offices of Canelones. They tried to set up these workshops in other places, so it's done in other towns as well, in other communities and rural communities, and so the experience begins to get shared between and other groups of women.
Hemos hecho encuentros de mujeres rurales donde nos
And we have done get-togethers of rural women, and they've shared their experiences together. Also, we have created projects to improve quality of life, and this has been in a camp in Parque del Plata, and it is with the funding from the Secretary of Sports, and they lent us the buildings and the spaces to be able to do a national encounter with women. And they get together annually for 5 days to work on these different issues, these rural women, but a lot of these problems are also shared by women in general and women in the city as well. These same women organize the project, they organize community projects, they have presented themselves in projects to improve their quality of life. What are some of the learned lessons? This meeting space has generated space in all of us, and we have seen its impact in everyday life. I will give it 1 minute, because back in 2014 we had a team which was interdisciplinary, and we were working on these workshops. And after a few years' work, those women wanted to participate as another woman themselves. They didn't want us to be just the coordinators of the workshop, but asked us as our personal opinions as women, of being our own mothers, or what we were scared of, and so we began to meet with this group, with coordinators, to decide what can we do. Could we, as a healthcare team, to join these workshops and really take away our armor of the healthcare process and healthcare workers, and just be women? And so, with some residents of family medicine and other team members, we participated in this group, the resident who goes with me, and we participate as a woman. And we participate as women, not as part of our job. So a lot of the time they coordinate the activities and workshops, but we participate as another member. In the construction of our health, we women are a part of this process. Rural women who are grouped together, they are powerful agents for change and creators of health. We know that they have a lot of knowledge regarding health, and we work through workshops and through everyday life activities. We take how they live, and we sometimes see it as a problem, but then we retake it up when they realize that there are things that they could have changed. And in this process, over the years, there are a lot of women who have decided to go back to school, have decided to start working from home. Some continue to live as they live, but they understand that this space has been reserved for them, and there are certain codes of conduct and they can respect for those who speak, for those who share without judgment. We can't judge others and their opinions, and in that space, which is careful and protected, and where we meet together, we are generating health and building health for ourselves and for our family and our community. Here are a few more photos. These are more recent ones. There you can see some of us working with manzanilla, with chamomile, and thank you.
Excelente, excelente, Marcela, la experiencia.
Excellent, thank you for sharing this experience. This is an experience which I saw be born, and it's been impressive to see how they've grown. And I believe that it's very interesting this how when we talk about mental health, we are used to thinking about the different health services, but counting how many psychiatrists, how many psychologists we have, but this is an example of an integral approach of social determinants and collective determinants as well. And I think this is has been very clear. Thank you very much. We would like to request that you can be as respectful as possible with time. We didn't want to cut you off because it's been very interesting, but we have 3 more experiences that are going to be shared, and I'd like Isaura Filippini to share her experience, which is related to the rural area as well in the department of Durazno. Thank you.
Well, we try to show you only 4 slides. In the first place, we would like to thank ISO and the Ministry of Public Health, because we think that this type of presentations and good practices, well, you know, we work up country and we don't know very well, people don't know very well what we're doing. And I think that all over the country there are very good practices that are not known. Obviously, I'd like to thank all the teams that have worked in this practice, and I would like to name them. I can't name them because there are too many. In our institution, which since 2011 has worked at first primary level and primary health care. Sometimes they say that it's a difficult job, but we have tried to do it, and that's not a minor issue. Our practice is interinstitutional fairs of rural health. The team involved are the ones you can see there on the screen. They compiled all the data because this has been very hard work. We would like to stress anyway that it's important to keep records, because if I don't keep a record, it seems that I haven't done anything. So this was one of the lessons learned in our institutions. To keep good records meant that we could be here today. Durazno, for those of you who aren't from Uruguay, we are located in the center of the country, about 183 kilometers from Montevideo. It's 2 hours, but when you have 90 kilometers inside the province itself. That can take you about 2 hours because roads are not good. And sometimes you have 3 days a week to go from one village to the provincial city, capital city. We are Camedur, that is part of the National Integrated Health Care Providers. We cover 33,000 users, and there are only 2 large providers, ACE and Camedur, for the entire province. I wanted to highlight that in particular because there are other provinces with more providers, but the large providers are between the public and the private sector. As regards the institutions, just to be brief, we haven't put them there, but I don't want to forget any of them. Our project started in 2011. We had 17 institutions participating: ANEP, ACE, RAP, IDES, BPS, Municipality of Durazno, INEFOP, Ministry of the Interior, Commission to fight TB, zoonosis team, Rotary teams, Lions Club, the Honorary Commission to fight against cancer. And this year we have dental area and health care for children. All of them have been trained at the beginning by the health department. The order they've been named doesn't mean that they don't share the same importance and characteristic to form part of the rural affairs. We have a rural population that is widespread, a few well-trained human resources, and healthcare upcountry. This means that in our province, with over 57,000, he corrects herself, of people, the rural population that is widespread is about 3,275 individuals. That means over 5% of the population. That population has been reduced due to the lack of access and the lack of work and access to healthcare systems. This shows, or I can show you some landmarks. One of the main landmarks is the year 2007, when the SNF was created under a law which governed everything we private providers had included in our management contract and our labor engagement. In 2011, there was a plan for rural health. There was a provincial health department, and that together with JUDESA at local level were most important. So since 2011, we have attended all rural fairs. All this was done mainly with ANEP because of their social and pedagogical mission. Through its schools, they could gather the schools, group them, and according to the needs found out in those schools, the teams were formed, and we approached them not only in health issues with promotion and care, but also through BPS. Everything has to do with social laws, IT, to have access to their records, contributions, etc. MIDES also provided special aids. So nurses at that time is something that we like to highlight here. The needs change, and participants also change according to the local needs, because social needs are difficult, because local needs are different. So nurses was only detecting hydathic cyst, and so there are that's no longer found. So their participation decreased, and they put something else in place, and so on. We arrived at 2019, which is the time where pandemic, there was an outbreak of COVID. But what we know is that by 2019, we were used to working in interinstitutionality and intersectorality, so that COVID vaccination campaigns was far easier, because we had a roadmap, and by ranking the vaccination system, we were the ones that were having the highest number of vaccination in our country. That was a big strength, because we had all the records for all those years. In 2021, we took up the activities, and we had a rural table, and the rural table of Durazno in dental health. And we started articulating from the rural health table an articulation with all the players was made. So we held a coordination meeting at the fair, and then an assessment meeting with further planning to record all the activities, and also through Como, through the schools and through the groups of schools, which early on in the year would give us their map with all the groups, and then on the basis of the assessment received from the teachers, we could know which needs there were, not only for school children but their families. And in that way, from the rural fair, we can go to those places to approach those needs. ANEP, through the Director Coordinator of Rural Schools, must plan the grouping of schools, coordinate dates, and so on. We are saying this because it's important to have an articulation, but also key elements such as ANEP to start developing where we can go and the prevalent issues there. Therefore, the complementarity of all our human resources and an ongoing assessment of all working sectors. An example of assessment is the work in dental health, because it evaluates and also awards prizes. A month ago, rural schools have homework to do, such as detection to see whether there is any bacterial plaque, and those students that have adhered the most, that have less decays and so on, they are awarded prizes. And so those children could come down to Montevideo to see the capital city and see Uruguay with their teachers and school groups. Perhaps for us here, it's not known, but that was their first time to come to Montevideo, to go to the football stadium and to watch Uruguay play, which for the first time it won. So there were also many other activities, that naturally come out from the organized civil society. Although this is an anecdote, it simply shows how we are targeting rural children and families and their needs. We have, as regards implementation, we always look into account and take into account the needs from the epidemiological and productive and social dimensions. We look into vaccination, we update it, we look at the schedules, we provide the vaccines, flu vaccines, HPI and COVID. We record whether the provider is a public or a private provider. We upload the information and we articulate it with the various providers. Whenever we make prevention and promotion, it's always free, independent of whether it's public or private, and they work in a comprehensive manner. If there's a PAP where a record must be kept in the Commission to Fight Against Cancer, then that should go, all those data should go to the provider that would make the follow-up. There are also health community agents. They are fundamental. The person empowered in the community is one of our largest strengths. Human resources in health does a very important community work. And as regards services, we have chronic non-communicable diseases. We used to have them with healthcare services. Now we do it with the Lions Club at the provincial level, and they have added up providing glasses if it's necessary, when something is detected, if the visual inability or disableness is detected, then glasses would be provided, and that's highly valued because that was a very high need.
All the workshops with a nutritionist who is always there with us. We also do workshops for the child, for the family and the community. This is done with didactic games and everything as applied as possible to the population we're working with. We talked about vaccination for COVID, flu or HPV. Also, we work on physical activity, so when we're doing different activities related to health, we also do recreational activities for children and adolescents in the area. We also do health education, which is applicable. We work on domestic violence issues, which is also done through these teams. And we have also found there are situations which are related, and we've been able to divert them towards the specialist teams. Regarding social funding that we and support that we have, that has also been, we give them information and consultancies. And then with regards to the Ministry of Agriculture and Farming, we've had both flooding and droughts, and in our area that has a very important impact, because for local production and farming during these periods, the important drought. But we've got a department that has a lot of rivers and streams, and there are problems where when they become dry, there's no communication, or sometimes we need to leave one part of the department, go to another department to get back to the capital of the department of Durazno. Those 100 kilometers aren't the same distance in the rural area as in another area. Regarding impact and results, we found that there's an improvement in accessibility and the use of health services and social services in rural areas. We found that these fairs have reached 3,896 people who live in rural areas. We've improved prevention, early detection of different diseases and risk factors, and therefore reducing rates of mortality. Regarding lessons learned, we've seen there's been an optimization of interinstitutional resources and interdisciplinary resources based on primary health care and these principles of equity, solidarity and community participation. And we believe communication between the teams is very important. The reach of the different things in this last year, we've done 9 fairs in 9 rural schools, which reunited 50 different schools, and we had 450 children and many other adults. And when we did dental services, we provided basic dental things. We gave 320 vaccines. We gave glasses. And one thing which is very important, how do we finance this? Financing for this and the funding, each member of the team provides their personnel, supports their personnel. We rotate the transfers sometimes. There are some institution plans who is going to be covering the cost for transfers. And one of the problems that we had was that healthcare and oral healthcare, we had some very graphic images. They're done in a chair. You tip the chair back, and sadly that is very basic. So what this generated is that from the rural society, they'd been seeing this for a long time, and with an important commission at the beginning of this year, we knew that Japan had donated a ambulance which was equipped with dentistry conditions, and so we were visited by an important team, and a project was approved. In 2023 there wasn't a project, so for 2024 one of the issues that we're working on, we're trying to have this kind of ambulance which is set up as a dentist office, and so we knew it had been a good experience in another department, and it allowed the access to dentist resources for these populations. So also I'd like to highlight something that's been mentioned greatly in these previous teams, which has been very important to all of us. From the beginning of this project, there have been changes of governments, changes of department directors, many changes, but even though the leadership has changed, they have tried to maintain by any of these institutions that these projects continue to be done with these rural fairs. So this activity, we have had a good experience of working intersectorially, because there have been many experiences. It has strengthened us greatly, and it has made the work a lot easier. Thank you very much.
Muchísimas gracias, Isaura.
Thank you, Isaura. Lovely experience. There's a lot to think about and dialogue. We would like to. We have very little time, so try to speak quickly, because we want this to become a dialogue where we can all interact and give our opinions and reflect together. Virginia? Good afternoon. A pleasure to share this project with you, with a team that has been developed in territorial and working on strengthening healthcare in the neighborhoods. This has been done by the Town Hall of Montevideo. So, in this sense, I'd like to share that the Office of Montevideo has been working in that this administration and the ABC plan for the local government has been a priority, and health has been a priority. The reality is that this has a long story in the town hall of Montevideo for different reasons. I was told I needed to share from 1994, sometimes 94, 95, but not only on a national level, but in this sense, the government of Governor Tabaré Vázquez, who came to power in 1990, he was a pioneer in highlighting primary health care as a strategy that needed to be followed by healthcare in our country. And so at that time, we generated these mobile clinics, and this is something that is still alive, and we still have a mobile clinic, Adela Dominguez, and to the day there's a lot of areas that continue to work with us, and we still try to do work in the territory. I can see our vaccine technician. She's been working with us for 15 years. So this has been a very positive experience for working on the territories. During the pandemic, this is another key milestone. We worked alongside the Ministry of Health to establish vaccination clinics or mobile clinics, vaccination points. We saw that not everyone was going to be able to access the online calendar agenda, and so we did a great job with these mobile vaccination clinics and points. And we learned over time the intense experience of the pandemic. We created and strengthened this strategy with the creation of other health mobile clinics. Mobile clinics ABC, I can see Santiago Castillon, Laura Esteves, nurse teams and family medicine from these mobile clinics. And they are the ones who are working in this strategy daily. And also we worked with the School of Dentistry and at the university, and they continue to work and give assistance, first assistant with the territory with the mobile clinics, and then they integrate with the School of Dentistry and the different dental clinics. And we're also working with Montevideo Rural, thinking that Montevideo isn't only a city, there are certain issues in other areas as well. So we're also working with Montevideo Rural. I wanted to explain these highlights or milestones because this isn't just a thought of the clinics going around the territory, but it's also of the Town Hall of Montevideo and local government to bring health to the communities. And I can see Ferreira, she's a coordinator of the mobile clinic Adela Dominguez, and she is always working with the other mobile clinics to be the Intendencia, the town hall. They are the ones and go to the territory and to the community. It's not just healthcare. And we visited more than 60 neighborhoods in the different municipalities, A, D, E, F, and G. And one of the things that our strategy implies is there have been different stages and cycles. When we created the National Integrated Health System, there were changes, but everything that is related to the system and the coverage and assistance coverage for most people, we think about universal assistance. It's a great achievement, but it does mean that there are still things that need to be done. And access in Montevideo can also be a problem, not only in the interior of the country. And so we have a very diverse city in Montevideo, and there are certain barriers for access. And depending on different levels, but also in the territory, is also difficult. And it's something that this government has decided to try and work on. We found the importance of intersectorally. This is a work which is done by the local government, and so in Municipality A, we reached the territory. It was something we generated a commission between services, so we also take people who work on and work with food safety and cleaning services for working on basic services such as water and rodents and other issues. Maybe this is the what unifies the work in the neighborhood, and it allows us to work in the territory other problems and not only healthcare, because there are many determinants of health for the people, and it's not only the assistant issues. I was thinking of these ABC clinics which are mobile, and there is a connection with the territory, and they go to the east of the country, and it allowed us to design a public space to try and get rid of a dump yard, and so beginning to work in that neighborhood where there was no organization within the neighborhood in the community through this mobile clinic and working with the community was a way that managed to change things, because we created this way of transforming a reality and creating a public space instead of a dump. And so this was also important because we see that there are many different realities. We find children who've had no controls, domestic violence, uncontrolled pregnancies. And so we found that they were detected in the territory when you go to the neighborhoods and you have a commitment and technical abilities and resolution abilities for these teams. In the mobile clinics is definitely admirable, and I believe that we need to adapt our proposal to each territory, to each community. It's not a mobile that goes to different places. This is a mobile that works with the community. It's a team, it's coordinators, and the team works with the territory, and they prepare the arrival of the mobile clinic. They decide where it needs to be placed, at what time they need to go. They also work the continuity and work with other areas of the local government. And this is also related with, it's a way of getting into a system for a lot of these patients, because they begin to interact with the network and the use of the informatic system, the coordinated work with the national health system, and the mobile is somehow the entrance to the system for a lot of these patients, not only the care they give there, but it's that entrance to other things. So here we have one of our colleagues during the vaccine. We had a colleague who went to all of Montevideo, and he continues to work with us in the territory.
I think that intersectoriality and care coordination is something I was able to do. Citizen participation as well. At a time when decisions had to be made to set up teams, we had lots of meetings in the council, town areas. The neighborhood town council held many meetings with neighbors, or soup kitchens as well played a key role to group everyone because they needed food. They would talk not only about their need for food, but all their needs. So it was important to talk with those people, mainly women. So it's important to bring in again this question of the territory. You know, I have this bus with 3 professionals. I would park it here. If someone comes in, that's fine. If no one comes, okay. But it's the need that we have to work with the territory, not only to organize the team's proposal, but to organize the municipality in other areas of work. And I think that has been a high point and a strength of this team. In a year, they have had over 77,000 consultations, not only the number, but how complex the realities are. I can see you down there, Karina, the back of the room. Whenever they come up to us, those are the hardest needs that come up to you, how complex the realities are. This is something that figures can't show. Strengthening of the neighborhood organization to get organized as a starting point to see how the bus will come in, how neighbors can get related and get organized has been an important element. And other things that the municipality provides, like providing glasses, different types of diseases, healthcare, presented as a way of being in the territory by the municipality and not simply healthcare. To conclude, I would like to ask you for a round of applause for Alicia Guerra, who retired last year, but she has been a historical icon. Without her and her commitment, the direction of this service wouldn't have been possible. Thank you, Alicia. Thank you, Virginia. I have thousands of comments to make, but I'm not going to make any. Eva Bustamante, you have 5 minutes. Because otherwise we can't have a dialogue afterwards. Let me be brief then. In 5 slides, it was very difficult to sum up all our work and results. You have a poster downstairs that you can check. I would also like to thank the opportunity for being able to share these experiences with you, to make them as a link and replicate them in other places. I'm here as a presenter, but there should be many more. I didn't know that we could include them. I would like to name all the team that work with me in this group of Healthy Heart. This team has been working for many years. I arrived last year to the Barrio Sur Polyclinic of the municipality of Montevideo because I'm a nurse, a graduated nurse. I collaborate in the coordination and the management of the team, of the group. But the group has been self-managing and is self-sustained. And I would like to thank Pajo for encouraging us to make this presentation. But above all, I would like to thank all those who form part of the group, who are the real protagonists. And to know that some of the members who are down there in the audience, Susana, down, they are all there accompanying all our proposals, and many more. The team of Adriana Sosa, Anas, who has been working with us for a long time, and coordinator Alicia Blanquet. I'm going to try and sum up our work. The group called Healthy Heart is worked in Barrio Sur in Montevideo. Started in the 90s. We did research work to find all this information. Many players collaborated. ODH or other groups collaborated and worked in many polyclinics of the municipality within the framework of PHC and also within the framework of the high prevalence of non-communicable diseases in our country. Groups that support these people with these diseases. And then along the time, there are several landmarks that I haven't included in my slides. Since the 90s until 2018, many things happened, but the group has taken different forms. It was formed by different technical teams. In our research work along this timeline, it was really working very hard as from 2018. In a participatory and collective manner, they gave themselves this new name of a healthy heart, which we think it's important to highlight because it was the individuals, men and women at that time, who decided to change the name and have a proper name. This year we started different activities, Zumba classes, teaching activities, museums, concerts, to promote culture, which is also part of our health. In 2019, apart from continuing with these activities, we articulated it with the academia, with the School of Medicine and the various schools participating in activities with our group. In 2019 and March 2020, particularly when COVID had its outbreak, we continued digitally through a WhatsApp group. We had Zumba classes, yoga classes, physical activities, in contact with family doctors that were working then. So there was a continuity all along the time. In 2021, when we could take back our face-to-face activities, we started with follow-up activities of these people in their checkups, following their non-communicable diseases. And we continued with activities related to participation and community activities. At the end of the year, we had a very important landmark, which is the community farm. And in 2022, 2023, I started knowing this activity in depth. Many activities have taken place all along a week with different proposals that people have suggested. We know that practice encourages the members of the group to be an active part of the group and to propose activities and see their needs shown and taken care of. We try to put up some photographs from previous years, 2018, 2019, even before that, in the teaching activities, guided tours to botanical gardens, to cinemas, to theaters, cultural activities, in the multi-use room that we have in the polyclinic. There are some contextual elements facilitating practice historically, as from the National Integrated Health System And as from the health reform, we had a good promotion to set up these groups in the various polyclinics. But for healthy heart, this was a fundamental support provided by the rector organizations, the municipality of Montevideo, that always had this perspective of social participation, integration, decentralization, intersectoral work, which we feel it's very important. We coordinate activities permanently with different services and sectors. Another element was to have adequate facilities. Our polyclinic has been improved from the building standpoint. We have a multi-use playground where we can have yoga classes, where we have more and more people. The room is getting small. When you were talking about mental health, once we expanded our conception of working in mental health, we believe that yoga is something that must be sustained in that physical room is a good facilitator. Then when the polyclinic started expanding, and then we had a patio where we have a little farm, and that's an element that facilitated practice. Human resources, it's fundamental to have human resources that are well trained, but also that we share love for all these things. Because after I complete vaccination, I go out to the garden, to the orchard, because, I love it. And then to work together. Whenever we promote an activity and something new to be done, there is collaboration. And we can immediately start working on it. Also, the participation of the academia as a facilitator of the practice, the participation of the residents and students who, along the time, are always participating in all practices.
There are a few other photos of trips that we have done in Montevideo and outside of Montevideo to other areas of the country. Some improvements that have allowed us to do this in the hour de service, a systemic integral approach with a respect for ethical principles, considering people at the center as neighbors and people who are the protagonists of their health of the group. We respect their opinions, their feelings and their demands. The learning process of the group in response to what was experienced, it has changed over time. The technical staff has been changing over time, but we are aware that that group needs to be sustainable over time. That's a challenge that has been for everyone, for all human groups, and we have managed to do that within the different challenges and the feedback between the different participants. Next person who comes along the team, this is a challenge that everyone takes on. Been working between interprofessional groups and the other institutions and the team at the polyclinic, with neighborhood committees and other institutions, homeless shelters. We're currently working with several workshops where we have people who live in the homeless shelters of the area and they come to our community garden, for example. We work with different coordinations on different levels with other key players from the local government. And then other important things is the protection of these spaces that are generated. We found that through this practice it's very important to highlight the feeling of belonging that it generates these people. And today those who are involved in our group Healthy Heart, they feel that their area is theirs, they feel at home, so that guard is taken care of in the way that they would take care of their own garden. They can come at any time, they come and work, and they use it as there are tools there where they can do some gardening. It has been donated by different groups. There's a lot which could be said. It's hard to summarize everything, but it's fantastic that we can do that. The feeling of belonging and the spaces that are generated. Another of the improvements that we found that allowed us to develop this is the people getting closer to other activities that are proposed by the polyclinic. There are people who are going from a stand to different fairs. They've been giving produce from the community garden or taking plants, and they share their experiences about the clinic and the yoga classes and the things they talk about their experience. And if you've got a midwife or you've got a nutrition in, and they suddenly seek care for other areas and aspects as well. The impact and the results, it strengthens a family approach and a community approach. And those who participate in the group, we know their history, we know their family, we see that there are a lot of family networks who all are seen at that clinic. And that generates important relationships. We create this project with the community garden. We have strengthened the relationships through collaborative efforts. It's important that there is a support for the group, and they feel it's a support for them. We have a WhatsApp group as well where we give a lot of support, and the team gives people give support to themselves. So if anyone needs something, someone else will organize. They'll explain how we can raise money. Someone who's having a challenge or needs having some difficulties financially, and the community has been building that. And also we have built stronger relationships with the greater community. We've gone to different activities for Global Child Days, for the winter festivities, and different activities that are done outside of the clinic as well. It strengthens those relationships with the community. And so they are very part of this neighborhood. This is the last shade, the last. As a lesson learned, the methodology of work, it favors sustainability over time. We have seen how it has maintained, despite teams and technical staff has been coming and going. We have seen the group has maintained over time. We have generated spaces for communal meetings, and it generates friendships and relationships between neighbors and colleagues from the group. And we have always heard that they find it really beneficial. And also there's a circular functioning between the group, and there's a continuous feedback, a circular feedback. I think there's a lot in common, and we have learned a lot. We know a lot, and we are part of them within the group, and so that horizontal relationships and working circular dynamics, that is very beneficial. And another lesson that isn't on the screen, but I want to highlight as my colleague and an auto-evaluation of the team, we learnt the importance of registering, systemizing processes, generating evidence to be able to replicate this in other spaces. I know that a lot of people do these sorts of things, but to systemize it was definitely a lesson learned. There are a few photos. You can see the murals. These are some of the milestones this year and last year. This was a process. The mural that was done on the outside wall of our clinic, it was designed and co-created by the group in several groups and workshops that we did. What did we want to represent in that mural? And they wanted to do it representing the Mama Vieja of the neighborhood. And so it was designed and everything that represents the neighborhood's culture. And some of those encounters, the yoga teacher, she's part of the group, the different activities and trips to events and the theatre, and our community garden, which has given us lots of good things. So, thank you.
Muchas gracias, Eva.
Thank you, Eva. So now we open the floor to dialogue to all of you. If anyone would like to share, we have a raised hand. We would like to ask you to be brief in your comments, 2 minutes, so the more people can comment, the better. Thank you. I'd like to congratulate you for your presentation. I think hearing the experiences is very motivating to continue to replicate them in other places. Considering some conceptual idea of social determinants of health and social environmental, I think we need to discuss commercial determinants in health, and I think we have commercial actors in this as well. So food services and alcohol producers and tobacco industries, and so they also have a responsibility. So for example, these activities, they are transmitting that they have a social role which is important, but they are contributing ill health to our populations. And considering private sector as well, we have patients who are class A and class B, where if you pay $10,000 more, you have better access to certain services, and I don't think that should be allowed to happen. And then another important factor, considering commercial determinants of health, is the action of marketing and marketing which is directed at children for consumption of products that is going to be negative for their health. Thank you.
Ahí había otra persona levantando la mano.
Sí, lo mío es muy breve. Son dos cosas.
A brief comment. There's an experience, especially regarding palliative care, and that's by Rubenito, who talks about compassionate communities, which has worked quite well. And I think this is an interesting model to be considered, because there's a lot of elements which are in common. And then another thing is a question that I've had from the beginning of this forum, but perhaps I think there's an important element of community, and I think, what is the place, do you think, or what is the role of home admissions, hospital admissions, but in the home? There are certain elements in the polyclinics that can't attend to that, and sometimes there's a challenge between the home and a hospital admission, and perhaps it would be better for a integral management of a home admission. There are more elements in common with a community network and an integral network of healthcare than, and someone said it in the previous forum, someone did it as part of the polyclinics, they would do home visits. I think that's very interesting, because it also gave time to spiritual management and spiritual dimension of health. I'd not heard about this, and I've been thinking about this. I think that I'd like to know your opinion on this issue as well. Good afternoon. I am Adolfo Alvarez. I'm from Cuba. I've been working 20 years. I've been working on social determinants. I'd first want to congratulate the organizers for making visible something which is often not given the visibility further than in the academia or in the politic discussion, and that's the social determinants. I think it's excellent that you have been able to get together a group of experiences, because that that brings the territory to the real role that it has, and it goes past the academia and the discussion yesterday. I think it was yesterday. We shared and presented the experience that we've developed, and I think it's excellent, everything that I've heard here. And we are willing to exchange and collaborate if you believe. We have developed a structure, an informatic system to be able to encourage community participation in these social determinants, and just that's it. Thank you. Congratulations once more. Good afternoon. How are you? Estela Arispe. I'm a nurse, and I work in the Faculty of Nursing and the national system. I'd like to consider about the women's group. This has an interesting profile with users who are female users. One thing that I find concerning, or what is your experience with participation of men? Because in some experiences which we're trying to develop in my activities, we find it's very difficult to get men involved in these sorts of activities, and this is a challenge to develop and think, how can we reach men from the community and work on these issues. Thank you.
Hola, buenas tardes.
Hi, good afternoon. Thank you for everything you have shared. Silvia Teixeira from the Uruguayan Society of Family and Community Medicine. I understand that this is very important, the community participation in this process, thinking about primary healthcare. We have seen many experiences which are very valuable, and these are just a sample of many others that perhaps haven't been presented today. But we are convinced from the perspective of family medicine that this is very important to develop healthy communities, people who are healthy, fulfilled. And we find it quite concerning when you find it concerning when there are certain issues arise, why we do specific community actions regarding our expertise in community work. We have found it quite concerning for this perception, because we understand that it has sometimes been professionalized when we have special professionals, be it family doctors, nurses, and other professionals who work in community areas. And this is a special concern that we've had a lot of the time, and we've been speaking in the community societies.
The question is, do you consider this is the right time, thinking about this regional forum and the national forum, so this community activity forms a real part of our services? with an adequate position, and seeing from how serious this work is, because not everyone can do this work, and community participation doesn't work with just one talk. So the true change that you can see in other societies, in other countries, we can see that there is a real community participation. It is there since the outset and since the execution of these projects. I'm asking this question because do you believe that this is the right time to say this must be part of the provisions that the country offers its citizens? Thank you. I'm going to start by the beginning. From what you said, according to the practice I work in, we have no conflict of interests. We don't promote commercial brands or companies. Our practice comes from the medical team with no conflict of interests. We would need managers to invest more in community work. And there I'm going to answer to what Silvia said. For community work, the first thing that we need is time for a PHC, time to be able to plan, to make a local participatory planning. We need time to plan, to diagnose, to know whether the community I'm inserted in needs palliative team or childhood care team, or whatever type of team. That's the first thing. After making a diagnosis, we can think of what type of work or how we're going to implement that action. It depends on the community it is inserted, whether it's urban or rural, with certain population characteristics. Those are the actions that we're going to take. As regards family and community members, we do have hours for community work. We have hours for care in the offices and at home. And many times we have palliative care with very little tools for those of us who are up country with very little medicine and very little equipment. When we go and pay visits at home, we detect the family and economic issues are present at that time. As regards the masculine participation that Estela said, with a group of women who have a partner who is a man, we have tried to get men closer to our activities with no success. Men are the ones that go to any consultation the least. Whenever we think about games, like playing cards or having a campsite, well, there are very few men attending. Anything that involves health in the various dimensions has been very little. I would like to answer Paolo. I haven't heard either. In the sense of what you said, perhaps it would be good if we could include it to the topic, in the topic. Perhaps we still have a lot of challenges ahead in PHC. And those challenges make us see what the initial problems are. But I think it's timely to think about what you said. I've never ever heard anything in relation to what you are affirming.
Desde la
Out of the experience I've had from my own personal standpoint, because I've also seen the experience of groups elsewhere regarding healthy hearts. You were talking about the visibility. I'm trying to order my thoughts because I haven't taken down notes. You were saying something about the visibility, and that was something that I was highlighting, that this should go outside the institutional academic environment, but that its users who have to be present to replicate its effects. When you were talking about introducing health at spiritual level, this has to do with the multidimensional determinants of health. In the Healthy Hearts group, we have discussed it at length. For some years, we have included yoga, and I would say that if some years ago we had thought about yoga in the health service, would be a recommendation that I make users. Well, I am saying you have yoga classes for free every week here. And there has been an enormous progress in relation to healthcare. We are at a historical time where we can't be alien to all that. There's a new reality that's demanding the introduction of all these practices. That some years ago we could see them as alternatives, and we are now transforming them as part of what we do. The same thing happened with the orchard, with the garden. We were talking precisely about preparing our own food, contact with the soil, to go back to nature. But in the middle of the city, in the middle of Barrio Sur, very close to the main avenue, we have an orchard, and we belong to a network of orchards. This is an experience. You know, we were talking about the post-pandemic experiences, and one of the things is to go back to what is natural, to go back to the resources we had available, and the spiritual health as part of that. And that is something that is a strength in our group. Now, as regards the question about men, well, the same thing happens, and that's a phenomenon that goes beyond these spaces. Women, historically, we women and the feminine gender is always trying to be linked and related to finding our own medicine. And here we have this experience where at present most of us are women in the technical team, and there is a predominance of the groups of women as leaders. We have a man who is a yoga teacher, but we have very few men. There was one last question that I can't recall. So I'll leave that to you. One last issue about the masculine side of this. I think this is a cultural battle that we have to wage against men in a patriarchal manner. This has a negative effect on the health of men. There are several social mandates operating on us. This is a man speaking, and that operate against us towards the development of full life. That forms part of a debate that the feminist movement has stated, reivindicating rights, but patriarchy as a way of organizing society, and it's there that we have to take into account the way people participate. Of course, there are social forces that have different components. Some have a stronger masculine component, but in general, in community participation, the large number are women, and that means that there is a large number of the elderly participating, and elderly men have a way of aging which is not that healthier, quite negative and quite problematic from all standpoints. I think that, but looking at a gender outlook, incorporate men as a factor that must be discussed and rethought for change. I would like to take up something that our friend said about economic determinants that have a strong impact on social determinants. Sometimes they are the big difference to change. There are many interests, profits that are related to the factors affecting health. And that's why it's necessary to have comprehensive policies that can approach both international policies and national policies as well as local policies. For instance, the question of food. That's a good example. We worked a lot on questioning a feeding model, increasing our consumption of salt and fats and sugars, and that is funded by marketing campaign of ultra-processed products. We had the labeling law, but how can that be related to community approach? Well, it's that legal rules aren't enough. It's not enough to have a national rule. You need, in the case of labeling, specific campaigns to work in the community to teach what hexagons mean and how someone can use the information from hexagon to define a healthier diet. So in any of these cases, I think that the question of local approach is essential, articulated with a global approach, and to evidence the profitable, the profit interests. We have discussed this with the Chamber of Industries, and we said that if they want to go on selling their products, they have to look for compositions that don't affect health in the way that we're doing. And they took up that message and they did many projects. But if that's not socially valued aspect, there is no surveillance, no changes can be made. The two things are possible. One thing is to build a socially strong value through healthy life, trying to avoid these factors, and on the other hand, supervision of the rule. I think that's one of the keys. And the step forward with Hexagon is very significant. If we compare it to other countries in Latin America, that's very good. But then you have to work on it afterwards. And the question of food, apart from the quality of food, we have to think about access to food. As Virginia said, soup kitchens shows that there is no equitable access, necessary access to food. And there are many ideas about this issue of having local circuits, thinking about food at local level. I think these are the important elements.
And so private providers in Uruguay are currently given a differentiated attention depending on their financial possibilities. Is a contradiction to the national integrated health service. There may be different, if waiting times are different, if the services that are provided are different, it contradicts the idea of the national integrated system. It ensures universal access and egalitarian rights and to access, and that is the model that we have. But if in the private system, no, in the public system, it doesn't matter whether the patient has or not any money. It's their direct right to have access. So this is a discussion that currently exists. There is a problem if there is a private sector needs to be discussed. There is a commercial value in certain private providers, and that needs to be considered. And what our colleague from Cuba commented, I think for us it's been very interesting over this years to share about the relationships we've had with different countries in Latin America and sharing our experiences, because this has been very valuable. We have seen it in other conferences as well. We had people from Brazil, from Argentina, and it's very interesting. We've been working on this with innovation and in social participation, which was organized by the with the collaboration of PAHO, and we believe there is an important tract of exchange, and there are negative effects, of course, but it does ease things a lot, and we think that this experience of learning from others, that is a key idea for any process of constructing policies, and I think that is very good, and that possibility. And we think that PAHO can probably facilitate this, and it can be regulated. It's not just one conference every 2 or 3 years. You can generate analysis instances for specific issues, and we in Uruguay we had several projects were presented to the Laboratory of Innovation, and it was 3 of them received prizes. We're following that idea that the colleague was sharing about registering and generating evidence and enabling systematization. That is a critical analysis of what we're doing to try and continue to improve. I'd like to close with one more element, the element of local planning. We have local committees, regional committees, and that tool, of course, gave us lots of possibilities, but we need to continue improving. We need to improve, we need to generate more preceptive diagnosis and situational analysis. The construction of diagnosis and a constructive collaborative methodology also needs to be dynamic, and then have a dynamic for defining priorities. The example that they gave about the users of the Cerro department, they defined 2 priorities. One of them was drugs and misuse of drugs, and there were 9 assemblies to determine what needed to be done, and then they've been working on that over the next few years. They've had a big movement of My Area Without Drugs. They created a network. They did an analysis of the factors in this territory of these issues, and so we were able to go from one experience to a strategy for a territory and an area. You have to systemize the process using the tools that the system has. You have to improve them so they can develop plans, diagnosis, and things that are coherent with internal priorities and adapted to each reality. We have very little time because we have to go down, but we have Virginia and one colleague over there, and then we'll have to close and go down. I'll be Bryce. Paula didn't leave us very long, but several issues that I wanted to mention about commercial determinants from the by the local government. We don't support an event which is supported by the pharmaceutical industry or the nutrition industry. There cannot be any elements of a promotion You need a calendar. You don't need the industry to provide it. We can give it to you. You need a pen. We can give you a pen. The industry doesn't need to do that. And so a lot of the time, we avoid industry, a pharmaceutical industry is giving us drugs that the patient doesn't need, and we wouldn't recommend it. But we're receiving the prescription because the industry is bringing it to us. So we have that established. This is very difficult. Many teams don't understand that. And we continue to receive, and we try to avoid this, but this year I discussed why we can have flags on the beach where we do fun activities and sport activities with industries, brand logos, because this is a discussion that needs to be maintained. The industry may need to be, because with their social and their sunscreens, people are going to be encouraged to use sunscreen. I can put a sign saying that we need to put sponge sunscreen. The industry doesn't need to be, it doesn't matter what brand it is, but you need the patient to use, people to use sunscreen. And so this is a continuous debate, and until we don't have a society and a community which is more trained in these issues, it is very difficult. And just to close this issue, two more things. One, a lot of the time, second and third level of care, a lot of time we talk about humanization of medicine. I hear a lot about this, and you've had palliative care, which should be available to 100% of the population that needs it, and there's a law. My mother is the president of the Society of Palliative Care in Uruguay, so imagine we understand this, but a lot of the time we seem to be discovering these multi-dimensionality, spirituality, family management, medical patient relationship, and this is something that primary healthcare has already been doing, and working with the community, working in the patient's home, and that is something that the family doctor has already been done. And so we have a patient-centered care. That is what family medicine is all about, and that is how the primary health care works. And however, we are often not given, or the colleagues are not given, the conditions to be able to do it correctly. That's another issue. And then finally, I'd like to say, and I hope that we can work as an integrated network and not fragmented levels, but regarding masculinity, my area of my doctorate is regarding gender as a social determinant in healthcare, and as a social determinant, we cannot just see them from the healthcare perspective. We've already spoken about that, but gender is another determinant of health, and it's another social determinant. But when we talk about social determinants, we don't very often talk about gender. So I'm glad that this was brought up, because we don't consider it very frequent. As Paolo said, women live longer, but they generally have a greater load of disease. And so as they are often the primary carers, that also has an impact on their own health. And so they live longer, but they live more alone and with fewer care for them, less care for themselves. And there are many inequalities regarding that. But considering masculinity, we've been working with on HIV directed to young men. We need to consider gender. We talk about women and men and other genders. Trans people have a life expectancy of 40 years, and that is very important as well. So we need to continue to work on this. And whilst we still have these mandates of masculinity, of being strong, and that care isn't something for men, whilst that is still considered, that services that don't consider a gender perspective in the training of our human resources, and we don't consider social aspects and the problematization of these factors, it was part of this example, they generate us disease. If we don't work this with the communities, the gender is going to continue being a a risk factor and a social determinant that causes disease, and gender inequalities are a reality. Thank you for these questions, because we can discuss a lot more, and it's a very great discussion. We can do it over coffee. Thank you very much. Thank you to the panelists, the participants. We are very grateful. It has been very interesting, all the discussion. Thank you.
Una cosita que me están...
One more thing they want me to say. We have to go down because the event continues in the amphitheater downstairs. You have a QR code which you